So, dear colleagues, I just wanted to give you a very warm welcome to, and on behalf, of course, of all of the steering committee, to this, our 10th AF Screen International meeting. So, I just wanted to give you a little brief look back into time. So this was a publication that Ben sent to me the other day, actually from the European Heart Journal, Cardiopulse, reminding us all that it was 10 years ago that this group was formed by the initial steering committee. And since then, I mean, quite a lot has happened, right? So here is the first image. Not to point out any age-related differences, but here I am 10 years ago. And so we could all see that, you know, the group has evolved, and over time, we're now 230 members across 42 countries globally. So that's quite an initiative that was started 10 years ago, I think. And we do have these yearly photos to remind ourselves. But most importantly, I think, there's been a lot of papers and interesting review papers that's come out of this group. And just let us remind ourselves, this was the first one, very highly cited circulation paper, screening for atrial fibrillation, sort of the landmark paper, I think, for this group. And then followed by searching for AF in the post-stroke population. And then we had the dementia paper, and then we had the consumer-led screening paper, and then hypertension and atrial fibrillation. And we also, of course, had 2 surveys from the group. And I'm very delighted to tell you that as of this morning, the embargo was released for this paper. Wrong way. For this paper, the recent onset atrial fibrillation paper that was just published in the European Heart Journal. So thank you all for your contributions to this paper. And I'd also like to thank our sponsors, of course, for this meeting. So with that, I think we could I'd invite my co-chair, Renate Schnabel, and we would like to welcome the first speaker, Professor Chris Gale, who will talk to us about the FIND AF algorithm in this first part of the meeting, which is about AI in AF screening. Welcome, Chris.
Well, thank you very much for inviting me. I've got 7 minutes to talk about the FIND AF program, so I'm going to rattle through things very quickly. If we have the slide up, there we go. Just pop it onto presentation. Good. Lovely. Right. We've previously shown that in the UK, using millions of records, that AF is now more common than the four most common cancers combined. The issue is that a third of cases of AF, or 30% of them, are undiagnosed. ESC guidelines recommend a number of approaches: post-stroke, prolonged monitoring, opportunistic detection as a class 1 in a high-risk comorbid group, and potentially screening with a class 2A for patients over the age of 75 or with high CHA2DS2-VASc score. The issue is that the yield from these approaches is low, and certainly the approach I don't think is the right approach. So in the UK, for example, the health check, 40% of people will turn up to a health check, missing the opportunity to detect atrial fibrillation. Look at the numbers on the bottom in terms of the yields. They're all relatively low. These are important numbers to remember in terms of going forward. So we wanted to solve that problem and align to current policy and guidelines and improve the early detection and management of atrial fibrillation, specifically addressing the digital policy in the UK, the prevention policy in the UK, and what was newly termed the neighbourhood care policy in the UK. So trying to reach all of those angles in an efficient, effective way. So we did a systematic review of current prediction models for atrial fibrillation, identifying the flaws in those, in which therefore to overcome the flaws and develop a new prediction model for democratized screening for atrial fibrillation. You can see some of the flaws there in terms of very long prediction horizons, up to 10 years, which are arguably irrelevant. and code lists that were not necessarily routinely collected. We also did a systematic review and meta-analysis of the current yields of atrial fibrillation. Again, remember some of these numbers. So in prospective cohorts, the yield on average was 2.75% for incident atrial fibrillation. And in those trials that existed, the relative risk between the intervention arm and the control arm was about twofold increase in yield. So we set up with a number of pathway partners, both deep and wide across the UK, both in terms of policy, domain expertise, but also implementation experts. And we developed a model called FIND-AF. And this model was based on a number of very simple code lists: age, sex, diagnoses or comorbidities, and we developed that in over 2 million patients' health records in the UK, primary care electronic health records. We used an AI algorithm, a relatively simple one, with random forests, and developed that to predict specifically the onset of atrial fibrillation within 6 months, so a short time horizon. The model performed very well, so the C statistic was high at 0.8 with a good Bria score. And we found that higher risk individuals had a 20-fold higher risk of atrial fibrillation in the following 6 months compared with lower risk, and a negative predictive value of 99%. So if you were risk score negative, you were not going to have atrial fibrillation. But one of our internal critiques was, when we looked at it, there were 72 predictor variables, and one could argue that that's difficult to implement. So therefore we developed with our international partners a 12-variable AI FIND-AF algorithm, and those are the predictor variables there. And we externally validated it in 11 million individuals from Japan, contributing nearly 8 million cases, Israel in the CLALIT dataset that was used for the COVID evaluations, in Canada, China, and of course across in the UK. The FIND-AF risk score, so this 12-variable model, externally validated, when we looked at it across the 5 cohorts, had a C statistic of 0.78, and compared with other risk scores such as the CHADS-VASc and the CHESS score. So increasing the prediction well beyond those other established scores, and showing that we can test this in other international electronic routine collected data sets for AF screening. Just as an aside, this microphone seems to have gone off, but so just as an aside, we found that patients with high predicted AF risks, what I call a pre-AF cohort, had very similar comorbidities to an AF diagnosed cohort. It's not surprising in a way. We then went on to do some CMR evaluations as a test case in a handful of patients, and found some very interesting things. So firstly, the pre-AF cohort, so high predicted pre-AF who don't have atrial fibrillation yet, compared with an AF cohort, so established AF, the AF cohort seemed to have larger atrial volumes and a lower atrial ejection fraction. But the pre-AF, non-AF cohort, compared with the AF cohort, seemed to have the same level of atrial fibrosis. Potentially, therefore, suggesting that FIND-AF can identify a pre-AF cohort that has a different phenotypic characteristic prior to changes in the size and function of the left atrium. So we then went on, based on those results, to do an implementation study. This is the pathway. This was a diagnostic testing pathway that was completely remote, no patient contact. So the patients had a CHADS-VASc score that was elevated, 2 and 3 for men and women. We then applied through their electronic health records the FIND-AF score. We then invited those patients by text to receive a Xenocor device and to use that up for 3 weeks, testing it 4 times a day and with palpitations if they ever had those. And we would report on those findings to the patient and to the GP and ask them to follow through with actions. So one of the reasons why we did this remotely is because we wanted to test a digital pathway, but we also wanted to reach out to the underserved populations who are arguably the patients who have the atrial fibrillation that's undiagnosed and are at risk. This is the flow diagram here. What did it show? A yield in the high-risk group of 4.5% compared with a low-risk group of 0.6, offering a risk ratio of 8.5. With the sensitivities, that's a disease test positive of 90%, positive predictive value of 4.5 because of the low incidence of atrial fibrillation, and a negative predictive value of nearly 100%. So if you did not score high on FIND-AF, you were very unlikely to have atrial fibrillation, and if you were disease positive, you were very likely to be detected. And that was detection using a diagnostic device. So what about the secondary endpoints and the safety? So secondary endpoint of those with detected atrial and diagnosed atrial fibrillation, 97% of them received oral anticoagulation. We found two cases of 2-to-1 AV block. One case of 2-to-1 AV block and one broad complex tachycardia. The number needed to participate, depending on the baseline, was about 26, but probably could actually be even lower, depending on what the control arm is. And the detection yield on the first ECG tracing was nearly 50%. So FIND-AF is now a certified medical device. We've had quite a lot of press coverage from that in terms of the excitement around this, in terms of AI to detect atrial fibrillation. We believe we've got a tool that can be implemented across health records. So in the UK, for example, 98% of the population have a health record. Our algorithm can be inserted into that in theory, and therefore everyone in the UK could be screened for atrial fibrillation. We've also shown that it can be used in 11 million people from a number of countries using their electronic health records that are routinely collected. So we're at the point now of a wide scale-up and implementation with a medical device. This is the team. And this is the AF consortium from around the world. I just want to thank them. This is not my effort. This is everyone's effort. And we couldn't do it without all those people. So thank you very much. And I hope I've kept to time.
Excellent. Thank you very much for the talk. I think we have a group discussion later on. So if there are no burning questions regarding specifically this talk or understanding, we would move on. Thank you for now. And would hear from Linda Johnson, how can we use AI to work smarter in AF screening? Linda, please.
So let's hope I find my slides here. So thank you to the steering group for having me. It's a pleasure to be here. Just very briefly, my disclosures, and in the interest of time, I'm just going to dive right into it. Obviously, if we could use an AI-only workflow in our screening, there's a great promise for that. But in order, I thought today I would talk about what kind of model would we need to use, and what do we need to know about the model to be able to use it. So the optimal model for screening is sort of the same as it is for a clinical workflow. It has to have perfect sensitivity so that you don't need to spend any time looking at anything but the detected cases. It's not enough that it detects only AF, because if we are monitoring for longer periods of time, we're going to see a lot of incidental cases, and it's not ethical to miss them. At the same time, we have to do this with an acceptable false positive rate, so we're not just spending our time looking at AI-generated noisy strips, right? And we have to be able to report this to the physicians or the technicians who are going to be looking at it in a minimal, easily accessible, understandable way. And then finally, you have to assume that we're going to have sloppy lead placements and perhaps various devices in different settings. And so you have to have a model that's as close to device agnostics or close to insensitive to lead placements as possible. And if we had this, what could we do? Well, one thing is that ECG devices are relatively cheap. If the model were also relatively cheap, then we could have a one-step only screening. We just do monitoring in all individuals. We don't need to enrich our populations. Another opportunity, which I'm not going to touch on again, is that you could possibly build AI ECG models that you triage the patient based on the initial portion of the ECG, and then you decide whether they actually need to wear the device for a longer time period or not. The challenges for someone who is not me, but an anemic character, would be that it's much easier to build a model if you have ECG context for the patients. So most models tend to perform better if you have longer recordings, because then the model can look at different parts of the ECG and it can use what it learned from the individual patient context to other arrhythmias in the same strip. And you need to be able to do this with a reasonable model size. So it's not too processor demanding and expensive to run. For a screening population compared to a clinical population, I personally think that the false positives are the key metric. So I'm going to talk a little bit more about that. This slide is ugly. I'm sorry. I drew it on my iPad. But essentially, it looks like this. Like, most studies will show that if you start detecting AF or you start looking for AF, you find it quite a bit quickly. And AF is actually the easiest arrhythmia to build an AI for, because especially long duration AF, because you have long portions of irregular arrhythmias, right? And so you're going to detect most cases pretty early. The incidentals work the same way, but the false positives don't tend to work that way. They tend to be more linear, because if you let your model run, you give it more of an opportunity to make a mistake. So I'll return to this ugly slide in a little bit. But before that, I'd like to tell you about a model that we built. This was in the study that we call the Dry Martini study, where we evaluated the deep rhythm AI. And I'm not going to go into any details except to say that the model is a complex network model consisting of 8 different AI networks. And we evaluated it in 14,000 patients, 200,000 days of ECGs, many, many man-hours of ECG annotation by experts, probably around 3,000 or 4,000 hours in total, happily done by many people in this room. And we found a model that beats ECG technicians working in clinical practice on false negatives. It had a 14 times lower risk of missing a diagnosis entirely compared to an ECG technician, but it did result in false positives that are a little bit higher than the technicians. Around 12 per 1,000 recording days for deep rhythm, compared to 5 per 1,000 days for the technicians. And in a screening setting, the false positives that would be a problem, I'm not sure if this points, yeah, it does, would be these ones, where the AI thinks that something is an actionable arrhythmia, where it's in fact a non-critical arrhythmia, noise or sinus rhythm, something you absolutely didn't want to know about, right? For deep rhythm, over 14 days of monitoring in a clinical patient, that would happen in about 6% of the patients, whereas with technician analysis, that would be a third as many, 2%. That's over 14 days of monitoring, and in a high prevalence population of arrhythmia. So in a screening population, you could sort of expect this to be a little bit, but not maybe so much lower. So to return to the ugly slide here, which is also white, so this might not work here. If you are doing a monitoring, an ECG screening study, and you're working here, maybe you don't need such a good model, because you're going to find you need a model that's sensitive for AF. It's not that hard to do. You're not going to have a huge problems with the incidentals, and you're not going to have a very bad problem unless you have a really bad model with your false positives. But if you're looking to work with longer ECG monitoring, you have a high-risk population, we actually want to find all of the AF cases, then you need to be employing a model that is good on the false positives. That's probably going to be the most important factor for you. And so if you're going to conclude something from this very short talk, if you're talking about AI for AF screening, I I would propose that you try to use a model that suits your purpose. Short intermittent ECGs, maybe a simple model is enough, but longer recordings, you're going to need a model that detects incidentals and is reasonable for your false positives. And people who make models, such as myself, actually need to put in the effort in providing people who are buying models and employing them detailed population-specific performance metrics. Thank you very much.
Thank you. And maybe for the group discussion, Chris, you could come up to the stage.
Linda, do you want to sit? And we can,
thank you.
we as
Yeah,
chairs
then
can
we-
stand up. Yeah.
Okay, for a question. Okay, other questions? Really, one very practical study and the other on longer-term ECG monitoring and AI algorithms to really detect, in our case, atrial fibrillation. Are there questions?
Paulus, go ahead.
Do we have? Yeah.
I have a question for Linda. Hi, Paulus Kirchhoff. Good to see you all. Great to be here. I don't think it's working, but
Maybe I can stand. You can take that.
okay. So Paulus Kirchhoff from Hamburg. Great to be here. Thanks for your talk. I was wondering whether this question of false positives and incidentals, how does that translate when you go to intermittent short-term recordings, which quite a few of us have done and quite a few data sets exist. So when you do whatever, an ECG once a week, or and then you end up with 100, but each of them is very short, of course. And can you comment on that? Is that safer against false positives than having a Holter ECG that may record for the same time but in one long go?
Yeah, I think probably you're going to have fewer false positives on the intermittent ones because at least the way we wanted to calibrate our model was for perfect sensitivity for the most dangerous things. And the reason why we did that is that we want to develop a model that can be used for direct-to-physician reporting of long-term monitors. And so it's sensitive to electrode disruption, and it's sensitive to noise, to over-detect it as VT. Because it was built that way. You have less of that on intermittent recordings. I think that you would, the trade-off would be that you have more false positives, probably for PACs and sinus arrhythmia being, you're going to have more false positives for AF, because the model is not going to be as good, based on my expertise, at differentiating that from AF. I have no data to back that up. That's what I believe.
Yeah, me too.
Linda, that was terrific. Really nice overview for many of us interested in AI in the field. We've been learning in our journey at iRhythm as well, and we're about to submit our third deep neural network model. And I think where the field is evolving is you might need multiple AI layers, right? So imagine a very high sensitivity AI model, which you've nicely described. Then the problem you have is false positives, and there's a risk that the technicians see so many false positives they fail to recognize something that's a true positive if they keep having to click delete, delete, delete. So you have a high sensitivity AI layer, and now what we're moving towards is a second layer that's high specificity, right? And that's already enriched with a prior probability based on the sensitive layer, not just the entire population. And then the last thing, I'm not sure how it is with UKCA and CE mark, but the FDA now is requiring post-market performance. So just as all of us, when you look at lead safety and you look at these lead fracture rates over time, you're expected now to submit to the FDA your sensitivity or whatever performance you require, either the point estimate or the lower bound of the confidence interval. So it's an active area of regulatory oversight.
Yeah, and that's just the data that you need for the FDA, right? I mean, ultimately, we need to convince the people who are going to be using the models as well, and I think they need even better data.
Giuseppe Oriani, congratulations to Chris for his nice study. One question, it appears that only a fraction of those who were invited actually participated. So can you comment on this? Among those who did not participate, probably there were very high-risk patients. Does the method for the invitation may count? Is it a matter of education, of social status? This remains an important question.
Yeah, you're well spotted. So on the title, I put 17,000, dropped down to 1,923. But I don't think that's a negative thing, because the way we designed this was for it to be inserted. In theory, it can be inserted into electronic health records, so it can just roll through all those records and present, as we did with the GPs, a long list, and those long lists are then sent invites and reminder invites. But I completely agree with you. The people that don't turn up, we know from numbers of studies, are more likely to people who are comorbid and have disease. We're thinking about how we can tackle that in terms of either sending repeat invites, or do you physically go out to these patients now who are high risk? But yeah, well spotted. But nonetheless, if you can get a patient to participate, the number needed to participate to detect was extremely low. So cost effective, I would have thought. And that's it. We'll develop that later.
Dan, you had a question?
Singer, Boston. When you say high risk and low risk, this is for Dr. Gale. When you say high risk, what's the cutoff? What percentage are low risk?
So we had we split it half and half into high and low risk based on the C statistic, on the performance value on that. But that margin would probably need to be changed depending on which territory you're in, and that's what we explored in the 5 geographies. So one of the results was that the actual the threshold might need to be moved slightly up and down, not a huge amount, between those. But yeah, so it's a good point. But the high risk group, we did the Gini score based on those, and we looked at the strongest predictors for that. All the results will be in a paper or in a manuscript, and you can look into that in great detail.
And then you said it was like almost 100% got oral anticoagulants.
Yeah,
is that based on a 12 lead? Just a single 12 lead?
That was based on the Zenacore device, which is a diagnostic device which we elected to use.
So you don't know the burden.
We didn't detect the burden, so one of the things we're thinking about is when we do continuous monitoring or whether we do intermittent monitoring. But at the moment, we were very pleased to see that when we write a letter to the GP, and it's an automatic letter, you've got AF, you don't have AF, or you have something else. Those are the 3 outcomes, and to follow and the follow-through guidance that was followed through. We were actually quite disappointed that it wasn't 100%, because they were eligible for oral anticoagulation, because part of the inclusion-exclusion criteria had been suitable for oral anticoagulation, not previously on it, and not contraindicated.
Thank you.
Okay, I think with that, we had a very short discussion, and we will have more discussions later on, but I think we have to move on to the next emerging topic. Thank you again, Chris and Linda. And now we come to the emerging topic of atrial myopathy and atrial fibrillation, a deep dive. And this session will be chaired together with Ben and Human. And I would like to invite the first speaker, Linyi Chen from the US. Please come up to the podium and report on your work in the ERIC study.
Thank you, Renata. Friends and colleagues, good afternoon. My name is Linyi Chen. I'm the director of the Lilly High Heart Institute at the University of Minnesota. Today, it is my pleasure to speak on this topic, significance of low echo left atrial strain. Other than being PI on NIH grants that support my research on atrial fibrillation and atrial myopathy, I have no other disclosures. In the next 7 minutes, we will touch on the following. We will start with a conceptual model to set the stage. Then we will address this question, what is left atrial function? And finally, we will show the significance of low left atrial reservoir strain. Ever since Dr. Philip Wolf's seminal publication in 1978 from the Framingham Heart Study, we have learned of this relationship between atrial fibrillation and a 5-fold increased risk of stroke. In the last 10 years, we have learned that upstream to atrial fibrillation, independent of atrial fibrillation, is an entity known as atrial myopathy that in and of itself is related to a greater propensity for blood clot formation in the left atrium, leading to embolization to the brain, resulting in stroke and brain infarct, and over time, cognitive decline and dementia. Within this construct, I would like to call out the importance of impaired left atrial function, because the impairment of left atrial function disrupts cardiac hemodynamics, leading to this cascade of events. How do we know that this is true? In the last few years, we received this grant from the NIH that allowed us to measure left atrial function from close to 6,000 echocardiograms in the ERIC study. The ERIC study is a biracial, prospective, community-based cohort study that started at the end of the 1980s. It enrolled close to 16,000 middle-aged individuals from 4 US communities. At Visit 5 in 2011 to 2013, close to 6,000 echocardiograms were performed. And with this grant, we were able to measure in 2020 left atrial function using both volumetric as well as spectral tracking analysis. But first, what is left atrial function? So this slide shows the change of blood volume in the atrium in the upper panel, coinciding with the ECG in the bottom panel. During systole, when the ventricles contract, the left atrium dilates to the maximum, receiving blood from the pulmonary veins. That constitutes the reservoir function. During early diastole, when the ventricles suck blood from the atrium, that is the conduit function. And finally, coinciding roughly with the ECG, the P wave on the ECG, when the atrium contract and force blood into the ventricles, that is the pump or the booster function. So having measured left atrial function using strain analysis and volumetric analysis from close to 6,000 echocardiograms, we published a series of papers to show the importance of left atrial reservoir strain. Starting with this, that was published in the Annals of Internal Medicine in 2023, led by Ankit Maheshwari and Faye Norby. In this paper, Ankit and Faye showed that left atrial mechanical dysfunction is linked to a higher risk of stroke in people without AFib or stroke. The 3 strain measures were categorized into quintiles, the best quintile serving as the reference. Shown in this figure, for both reservoir and conduit strain, as compared with the best quintile, the lowest quintiles for both reservoir and conduit strain were related to a higher incidence of stroke. Note, in people without AFib or prior stroke. We did not observe any significant association between contractile strain or left atrial volume index with stroke. Moreover, when we added left atrial reservoir strain to the CHEST-VASc score, we observed an improvement in risk classification of ischemic stroke. The improved classification was driven by correct reclassification of people who developed stroke. Specifically, 12% of people who developed stroke were correctly reclassified, as opposed to only 2% who were incorrectly classified to a lower risk. Next, dementia. So this paper was published in JAMA in 2022, led by Wendy Wang. In this paper, Wendy showed that several measures of left atrial function, notably left atrial reservoir strain, were linked to a higher incidence of dementia independent of AFib and other dementia risk factors. Similar to what we observed for stroke, we did not observe an association between left atrial size and dementia. So this slide shows the 3 strain measures, again categorized into quintiles. The best quintile represented the reference. For all 3 strain measures, as compared with the reference, the lowest quintile of each left atrial strain measure was associated with a higher risk of dementia. The strongest association was with left atrial reservoir strain. It is important to quantify the contribution of AFib to these relationships. So we performed formal mediation analysis and found that the contribution was minuscule. Even in the biggest contribution, it was left atrial contractile strain, and the contribution was only a mere 1.6%. And finally, earlier this year in stroke, we showed that among all candidate markers of atrial myopathy for the composite of ischemic stroke and dementia, a low left atrial reservoir strain is the best predictor. Shown here are possible candidate markers, including ECG, echocardiographic, and plasma biomarkers of atrial myopathy. And we found that a LA reservoir strain of less than 29% had the most optimal prevalence, absolute incidence rate, as well as relative risk reduction, relative risk of the composite outcome of stroke and dementia. Moreover, when added to a base prediction model comprising the chest-vest variables, a left atrial reservoir strain of less than 29% was associated with the greatest improvement in model discrimination and the best model prediction error. In addition to stroke and dementia, we have shown that a low left atrial reservoir strain is independently linked to a higher risk of heart failure, this was in Jack, a higher risk of atrial fibrillation, and in fact, it does a pretty job in predicting AFib when added to other prediction models, and this was in EHJ cardiovascular imaging, a higher risk of CKD, a higher risk of frailty, and finally, this year, just 2 weeks ago, a higher risk of mitral regurgitation. So, friends and colleagues, atrial myopathy is an independent risk factor for outcomes previously attributed to AFib, such as stroke, dementia, cardiovascular outcomes. Therefore, targeting atrial myopathy may be a key strategy to preventing cardiovascular outcomes and dementia. I'd like to thank all the members in my lab, various investigators in different studies and cohorts, and the NIH, some members of my team, and I would be delighted to take questions. Gracias.
Thank you very much, and I like it that you say atrial cardiomyopathy is an independent predictor, at least if not a causal factor, of stroke and other heart outcomes. Let's move on, and it's a pleasure to have here Julie McCullen from Australia, and you will tell us a little bit on the other end, on the basic biology of PI3K, atrial dysfunction, and lipidomic signatures. Julie.
Thank you, and I'd just like to thank Ben and the steering committee for the opportunity to give this talk. And so my interest in PI3K really came about because of my interest in understanding the molecular mechanisms of physiological hypertrophy versus pathological hypertrophy. And so, for instance, we know from genetic mouse models that the insulin-like growth factor 1, or IGF-1, and phosphoinositide 3 kinase, PI3K pathway, plays a critical role with physiological enlargement. Whereas with pathological hypertrophy, other pathways downstream of G protein-coupled receptors have been implicated. And so to try and understand these differences, we've used mouse models. Our pathological model was one of pressure overload, as shown here, and our physiological model was one of exercise swim training. And so when we look at echo, cardiac function or ventricular function is only depressed in the pathological model. There's only fibrosis in the pathological model, and they have a very distinct molecular distinction. In this case, we really focused on the ventricle. More recently, we've been very interested in the atria. We couldn't look at it at the time because the atria in mice is only about 2 to 3 milligrams. And so just to briefly outline our work on PI3K and why we've been interested in that. And so we generated some mouse models with increased PI3K in cardiac myocytes alone. And then when we do this, we get an enlarged heart, which was representative of physiological hypertrophy. These mice have normal heart function, no evidence of fibrosis. We also have a mouse model with reduced PI3K in the heart called dominant negative PI3K. These hearts are significantly significantly smaller, demonstrating that PI3K is critical for normal postnatal heart growth. But interestingly, their left ventricular function is pretty normal. Now, we subjected these same mice to our swim exercise model. In control mice, you can see that there's this increase in heart size, but this is blunted in the dominant negative PI3K mice, demonstrating that PI3K is critical for exercise-induced hypertrophy. So we then wanted to know if increasing PI3K in the heart would be beneficial in disease settings, and so we subjected the mouse with increased PI3K to cardiac stress models, including pressure overload, and also a model of atrial fibrillation. What we found was that increasing PI3K was associated with better cardiac function, less pathology, or improved lifespan. Now, when we did the same in the dominant negative PI3K mice, even though they have relatively normal ventricular function, we found that in these stress models, we saw accelerated heart failure and we also saw atrial fibrillation. So we then wanted to really understand differences between atrial enlargement in physiological and pathological settings. Now, in this case, we turned to our physiological model, which was overexpression of the IGF-1 receptor. This is a model of physiological hypertrophy, and IGF-1 is released in response to exercise. These mice have enlarged ventricles and enlarged atria. We then had a pathological model, which I'll refer to as heart failure and AF. These mice have very dilated ventricular chambers, enlarged atria, thrombi, as well as fibrosis. Now, when we looked at ventricular function, you can see that fractional shortening is elevated in the IGF-1 receptor model, but not the heart failure and AF model. ANP is only elevated in the LV of the heart failure and AF model. And you can see that the ECG trace is very irregular. So we then characterised the atria in these mice, and what we found was that the left atria was elevated in both models to a comparable degree, but left atrial ejection fraction was only lower in the heart failure and AF model. There was only fibrosis in the heart failure and AF model, and once again there was a very distinct molecular signature. In this case, I'm showing proteomics data. Now, quite recently, we also wanted to understand the role of PI3K in the atria. Now, I previously showed you these PI3K mice with less PI3K, with smaller ventricles, and they also have smaller atria. These were heterozygote mice. More recently, we've generated these homozygote mice with a further fall in PI3K. What we then find is that we actually get enlarged atria, and thrombi are very common. Fibrosis is also only present in the homozygote mice. Now, I said that the dominant negative PI3K mice had relatively normal left ventricular function. But interestingly, when we looked at the atrial function, what we found was that they have reduced LA ejection fraction, and this is even lower in the homozygote mice. We've also done quite detailed proteomics in atria from these different models. So what's the relevance of this pathway in humans? Well, we know that risk factors for AF, including increased age, obesity and diabetes, they're all associated with depressed or defective insulin IGF-PI3K signalling. And so we had access to some atrial appendages from patients with AF, and we saw a fall in the phosphorylation of the IGF-1 receptor and a fall in PI3K activity. There was also a recent paper in Nature Genetics, which was a meta-analysis of genome-wide associations and polygenetic risk predictions of AF in more than 180,000 cases. Interestingly, when they looked at 5 lines of evidence to prioritise genes from the GWAS loci, the IGF-1 receptor was one of the main genes that came out, and they found that a decrease in the IGF-1 receptor expression was associated with increased risk of AF. I just want to highlight this very recent study which looked at reduced LA reservoir strain prior to LA enlargement and LV dysfunction. This was a mouse model of transverse aortic constriction. They looked at this in both 3 days and 4 weeks, and what I want to highlight is at 3 days there was no change in LA volume. There was a decrease in LA reservoir strain at 3 days, and this was before any change in LV ejection fraction. So we've also done some molecular profiling between these different models to look at potential biomarkers, comparing the healthy and the diseased heart. And quite recently, we've really been focusing on the metabolome, and we've been focusing on lipids. And that's because the lipidomic profile really captures the biochemical effects of both genetics and lifestyle influences, and obviously close to the phenotype of the heart. We've been very interested in biomarkers related to the PI3K pathway. So we literally have hundreds or thousands of different lipid species within our cell membranes and organelles. We've been very focused on lipids which can impact the IGF-PI3K pathway, shown here. So we had access to some plasma from some diabetic patients, and we know that diabetes increases the risk of atrial fibrillation, and we looked at different lipids. And interestingly, there are a number of lipids which helped us predict atrial fibrillation at baseline, but also future AF, and a number of these lipids were related to the PI3K pathway. And in a very recent study, we also looked at lipids within plasma from veteran athletes. Now, exercise typically protects us against AF, but there is a small cohort of athletes which will get AF. And interestingly, when we looked at thousands of different ratios of lipids, those lipids that were most related to AF were lipids related to the PI3K pathway. And I just want to end, I guess, with a hypothesis that Ben and Renata and I have come up with, which is related to the fact that a lot of risk factors for AF are actually associated with decreased PI3K, including hypertension, insulin resistance, an increase in inflammation, physical inactivity or overactivity. And what this graph is meant to be highlighting, here we've got left atrial function in blue and left atrial dilatation and LV dysfunction in red, is that early LA dysfunction and circulating biomarkers related to defective PI3K signalling could occur before significant changes in LA size and LV dysfunction. And with that, I'd just like to end by acknowledging all the people in my lab who have helped with this work. Thank you.
Thank you very much, Julie. And now we come to the trial. Arcadia in the USA, silent MRI stroke outcomes, whom you will report on, and then we'll go on to the AIMS trial in Australia, and Ben can talk a little bit more on that. Human, please.
All right. Hello, everyone. Very excited to be here and talk about some recent data from our Arcadia trial, the Arcadia MRI ancillary study, and then how that ties into the AIMS trial. Here are some disclosures before I start. And we talked about this at last year's meeting, but just as a quick recap, based on some of the observational data that we and others had found over the past decade, linking markers of atrial myopathy or atrial cardiopathy, atrial cardiomyopathy, whatever you want to call it, with the risk of stroke independent of AFib, starting in 2015, we applied for funding from NIH for the Arcadia trial and started the trial in 2018. And we recruited patients who'd had a cryptogenic stroke of undetermined etiology or embolic stroke of undetermined source. And then instead of randomizing them to anticoagulation or aspirin, that overall cohort, we only randomized the patients who had some evidence, some biomarker evidence of atrial cardiopathy to either apixaban or aspirin and followed them for recurrent stroke. And we used pragmatic atrial cardiopathy biomarkers. This was based on the pilot data that was available then. This is back in 2014, 2015, and things that we thought were feasible in a multi-center trial. So we used P-wave terminal force on EKG. We used NT-proBNP, and then we looked at left atrial size on transthoracic echocardiogram. So if patients met any of those three criteria, they were eligible for randomization in Arcadia. And in our primary analysis of the 1,015 patients who were randomized, there was really no benefit at all of apixaban over aspirin for recurrent stroke. And this was true when we just looked at ischemic stroke, and it was true across subgroups as well. We really were not finding any signal of benefit. But more recently, our collaborators on the Arcadia MRI trial finished analyzing that data and published it recently in JAMA Neurology. And this was a subset of the overall Arcadia cohort. So in order to be eligible for the Arcadia MRI trial, you had to have gone for at least 3 months after randomization in the parent trial and still be on study drug. And so and you have to have a baseline MRI, and then you got a follow-up MRI at the end of the trial. So of the 1,015 patients, about 799 were screened because the ancillary study started a little bit later than the parent trial. Ultimately, they ended up enrolling 310 patients from the overall trial, and many of the patients who were not randomized were those who had already stopped study drug. So there was a fair amount of study drug discontinuation, especially during COVID. So we started in 2018, and things really were tough in 2020. So this ancillary study really selected for patients who were more adherent than the parent trial, so just something to keep in mind. But 310 patients, and then there were a bunch of people who were excluded because of imaging data, and ultimately there were almost a little bit less than 200 patients enrolled in Arcadia MRI. And in contrast to the parent trial, where we found no benefit of apixaban, the Arcadia MRI trial sub-study was positive for its primary endpoint, which was embolic infarcts on MRI. So non-lacunar covert infarcts occurred significantly less frequently in the apixaban arm than in the aspirin arm. And even when you combined both the covert and symptomatic non-lacunar strokes, that was also significant, and there was really no association with other types of stroke, specifically lacunar infarcts. So what does this mean? I mean, we're obviously very excited about this finding. I would point out that one of the imbalances in the trial, you see that the patients who were randomized to apixaban were further out from their initial randomization than the patients who were randomized to aspirin. So again, you had to be adherent to the study drug in order to be included in Arcadia MRI. So potentially selecting for patients who were more adherent a little bit in the apixaban arm. On the other hand, I think if it were just an issue of, a chance finding or confounding, we would have seen differences in the lacunar covert infarcts, which we didn't. So a lot of factors at play, but overall, a sort of positive finding from this ancillary study. And in a related note, another analysis that we're wrapping up and have just submitted for publication was the analysis of hemorrhage endpoints in Arcadia. And what's interesting is that although the numbers were small, there were actually significantly fewer intracranial hemorrhages in the apixaban arm than in the aspirin arm. And most of those intracranial hemorrhages were subdural hematomas, which were more, numerically more common with aspirin than apixaban. And this was true in the Arcadia MRI ancillary study as well. When you look at microhemorrhages on the follow-up MRIs, there were numerically fewer microhemorrhages as well. So sort of consistent with the hemorrhage endpoints in the primary trial. So all of this, I think, ties into the idea that I'm not sure that the targeting atrial myopathy with anticoagulation, I think the story may not be over after Arcadia. I think there's questions about what the right biomarkers are. We just heard about left atrial strain, which I think is a really important and exciting potential biomarker, and that's what will be tested in the AIMS trial, which Ben can speak more about. But the AIMS trial is taking the same concept of identifying patients who had a stroke of undetermined source, and then this time selecting them based on either enlarged left atrial volume or reduced left atrial strain, and then randomizing them to a direct oral anticoagulant or standard care, which is going to be generally aspirin, and then using a win ratio and looking at outcomes including recurrent stroke. So I think there's still a lot more to do in terms of seeing if atrial myopathy or atrial cardiopathy is a therapeutic target for stroke prevention, and I think the implications from the Arcadia MRI sub-study is that study drug adherence is key. I think that we're working on an on drug, like per protocol analysis of Arcadia. That's also sort of suggestive. But I think study drug adherence is key. We definitely need more accurate biomarkers. And then I think the if you're going to use a DOAC, apixaban, based on those hemorrhage data, has a really strong safety profile when you're trying to choose between the different DOACs. So I will stop there. I'm sure Ben has more thoughts on the AIMS trial.
For now, thank you. And I would like to invite up the speakers again for the group discussion.
I think,
and Ben, you can.
I'd just like to say that working with Human inspired me to form a heart-brain collaboration in Australia with Mark Parsons. I was also struck by the data from Julie McMullen about the importance of left atrial strain, the data from Linyi Chen. Also, because even in the mice, when you reduce the PI3 kinase, the very first abnormality you see within days in an acute pressure load is low left atrial strain. I think it is an exciting biomarker, and that's the reason why we decided to use it as the primary biomarker in the AIMS study. It'll be exactly the same people who we enrol. Almost no one gets in, and the same in Arcadia with the large left atrium. It's nearly all low atrial strain. But we will embed in it a cohort study. So if it's not successful, we might understand more about what it really is. But to me, low left atrial strain seems a unifying concept whose time has come. It's very easy to measure. If we don't concentrate on the ventricle, we just change our echo probe up to the atrium. And it has prognostic significance, and I think it will have therapeutic significance. So that's what this is about, and this is what's excited me in the last 2 or 3 years.
Excellent. Yeah, maybe I can interrupt here and say my critique would be left atrial strain is not that easy to measure. So how many, you said you had over 6,000 echoes, but I would guess that you could not measure all the different strain types in all these 6,000 echoes, because we are trying to do the same, and it's very difficult. Although it's done automatically, our inter-observer variability of strain measurements is quite high. And to really have a good image of the atria to permit strain measurement is not always given.
Okay, thank you for that question, and I'm not sure whether this is on, but...
No, it's
it is
on.
now.
Okay, yeah, thank you for that question. So this is an often, levied criticism for all our studies, and we can easily respond by saying that in the ARIC study we had shown that the measurement of LA reservoir strain using vendor-independent software, doesn't matter, it's Tomtec, Philips, etc., results in excellent intra and inter-observer variability. So we showed that in the ARIC study, and we also showed that in a pilot sample in preparation of an AIMS-like trial known as Creativity. So I would say it's easy and reproducible. Thank you.
In an individual patient, in the AIMS study, we have chosen only those echo labs that can do it. We have a centralized way of, we have a centralized model so that we will use non-vendor specific Tomtec, and we will have a core lab. And that will be possible to do the trial in individual patients. We have very good inter-observer and intra-observer reproducibility, which is crucial if you're going to do a trial. Otherwise, you would need to do a trial of about 10 million patients. If you want it in just 750 patients, you can use this particular method. It's just that we're not trained or we don't do it properly.
Are there any further questions? Paulus.
Thank you very much. I've got a question to that mouse model. And now, I was really intrigued, and I do think we all accept that heart failure and enlargement of the heart and atrial fibrillation and ventricular arrhythmias go together. And I had this slightly provocative thought, are you proposing that PIK3 is the new CAM kinase 2 that is involved in everything, and do you actually think that you can also improve cardiac function or prevent atrial fibrillation by tinkering with that system, or will every imbalance in the end make things worse?
So what we have done is we've the IGF-1 receptor mouse with increased PI3K with our heart failure and AF model to make a triple transgenic mouse. When we do that, we see a decrease in atrial size, we see better ECG rhythm, and we see less fibrosis. So I do think activating the pathway will be beneficial. It's not like you then get a supersized atria. The other thing to note is that there wasn't time, but we're specifically looking at a class 1A PI3K, which is PI3K P110 alpha. So there are another PI3K isoforms which are implicated with G protein coupled receptors and calcineurin.
Thanks for bringing that one up, Paulus, because it's much more complex than a simple cardiologist like myself could comprehend, which is why I must work with Julie, and why it's so good to have a basic biologist as part of this group.
Good afternoon. This is Diana here from Malaysia. So this question is dedicated to Prof. Lin. I'm here. Yeah. So the importance of LA reservoir strain is well recognized that in current guidelines it has been included as part of the diastology assessment to estimate feeling pressure. But the cutoff suggested is much lower, which is 18%. So I noticed from your lecture earlier that you're suggesting a much higher strain value of 29%, which is associated with adverse outcomes. So if this is a case, instead of focusing on what's normal or what's abnormal or reduced strain, should we be focusing on a value which is associated with adverse outcomes, a higher value which we can intervene early in a clinical practice?
Okay, great question. So I'll turn that back to Ben. What are you using in AIMS for the left?
We are using 23%. The reason for that is it was found in one post-stroke study in Australia looking at prediction of post-stroke AF. 23% was the best cutoff of reservoir strain. In another study, which was a post-stroke study in a single centre, they looked at the best cutoff between patients who had AF and a stroke in small vessel disease. And the best cutoff was 23%. So this is the one that we're using. However, in the cohort, we will have the range of anything between 23 and whatever it is, and we will be able to look at in a sort of continuum. But at the moment, I think even in the loop echo sub-study, unfortunately, he couldn't be here, Fleming Olsen, but in that study, the cutoff was a bit higher. So I think the cutoff will need to be looked at. It may depend a bit on your vendor-specific or non-specific type of device, but it's a good question.
Yeah, so I think, absolutely. So I think this is an unsettled question right now, and that's the reason why in our group we took great pains to publish that paper in Stroke to show for the record that we will be using 29%, but with an adaptive, trial so that we can modify during the trial. And also, as Ben mentioned, I think in post-hoc analysis, that gives us an opportunity to really define what the cutoff should be.
Yes. Within the AIM study, the cohort will be those whose strain is above 23%, and those whose strain is below 23% given aspirin, which is the control. They will form the cohort, and in them we will also be doing 12-lead ECG AI. We will also be doing biomarker studies that Julie is going to be working on. We will do mid-region ANP rather than BNP. So we may find an answer even if the trial is negative.
And Human, is it possible from Acadia to measure strain post-hoc in these echoes? So are you?
Yeah, so the echoes are at Columbia, and there's talk about doing it. I think it does seem like it's pretty labor intensive, but yeah, it's available. It'll be great to do that. I think we just have to figure out the mechanics.
Hello, Professor. Hello, Professor Cameron. I'm Dr. Enping Kai from China. So actually, just now you mentioned you use NT-proBNP more than 250 to define left atrial myopathy. So my question is that, because I did not read the paper, so where did you get the cutoff to define left atrial cardiomyopathies? And then do you have any data to relate the NT-proBNP to left atrial stent? Because I know you currently only have left atrial diameter, but just now Professor Chen has showed that actually left atrial stent may be better than the size of the left atrial. So my question is that in the future, will it be possible to show whether there's any possible relationship between NT-proBNP and left atrial strain? Because our recent study in just shows that actually NT-proBNP increase with the ages. So actually in our cardiologists, we use the FIS cutoff to define pre-heart failure, but our study is showing that if we use age-specific NT-proBNP cutoff to define pre-heart failure, actually age-specific will be better than the FIS cutoff. So actually my advice that maybe in the future, maybe we need to consider use age-specific, but not the FIS cutoff.
Yeah, absolutely. No, the great question. So we got the 250 from, we had observational data linking, showing an association between NT-proBNP and stroke. And so for all of our biomarkers, we used the threshold that was associated with a doubling of stroke risk. That was sort of just the decision we had to make because we didn't have a lot of clinical trial data. So that's where that 250 came from. And yeah, we definitely debated using age stratified levels, but we just didn't have enough pilot data at the time. As far as the question of the relationship between NT-proBNP and left atrial strain, I'm not sure of that in the general population. I think one criticism we got for Arcadia is that we did not have a lot of patients with a lot of left atrial enlargement or very high NT-proBNP values. And I think part of the reason for that is those patients probably were screened for AFib and they had some amount of AFib and they were kind of, treated with anticoagulation as standard of care and didn't go into our trial. And I think that's one interesting question with, left atrial strain is, do we like if someone has a normal size left atrium and they just have some subtle left atrial, mechanical dysfunction, is that enough to get, left atrial thrombus forming? So I don't know. I don't know if the answer is to go to more sensitive measures or if you want to go for more severe disease. But if you go for more severe atrial myopathy, those patients will have AFib, and most stroke neurologists are not going to, they're not going to randomize those patients. They feel like we already know the answer.
Yeah. Well, I think that our stroke neurologists, if the left atrium is large, they tend to sort of believe that's a problem already. Very few got in for that reason, with that large left atrium. It's mostly NT-proBNP. We know from the Stroke Stop 2 study that NT-proBNP, if used, can actually enrich the AF yield, but I'm not sure if that's the best marker. And the group with Mira Katan in Switzerland is using the mid-region ANP as their best biomarker of atrial myopathy, and they've got a Moses trial that's in place at the moment.
Philosophical question from should age be involved in the severity of atrial cardiomyopathy? Because we know persistent atrial fibrillation in a young person is not a risk factor for stroke per se, but he might have a diseased atrium because otherwise he would just have PAC, a lot of PACs instead of atrial fibrillation. So, and we know from the RESPECT ACES trial, I think that oral anticoagulation elderly who had triple stroke indeed was protective.
Yeah. No, and so the first subgroup analysis we jumped to do after we got the neutral results was that age over 75, because that was the subgroup analysis in RESPECT. And then there was another trial, Atticus, which also looked at patients with cryptogenic stroke. They also, in a post-hoc analysis, found the benefit in people over 75. So we're hoping to see that in Arcadia, but there's just no signal with age at all. So yeah. I don't know. I agree with you that you would think that this would be more prevalent in older patients, but...
And Linyi, in the ARIC study, what was the age range?
Yeah, so for the trial that we're planning, it would be greater than 65 years, but we pre-specified a subgroup analysis at 75 years, precisely on facial recognition.
Yeah, so I don't think we know the answer in the young people.
Yeah, we are behind time, so I think although there are more questions, then maybe we need to postpone them. Ben, what do you think?
Yes,
to
I
the
think we'll
coffee
probably
break?
postpone it to the break, and hopefully we can talk about it in the break and in the break after the break.
So with that, I would again thank the speakers. Thank you, Julie. Thank you, Lynn. And we would move on.
All right. And I think I'm going to introduce Ben for the year in review.
Well, thank you very much. So, the year in review. So this is our 10th year. And so I think we will call it from now on the AF Screen International Collaboration, at least for this year. Last year when I had to give the year in review, I said, hey, I'm alive and here again. And yes, hey, I'm alive and here again, but I guess there's nothing new about that. This is our largest meeting yet, more than 70 members attending. We have lots of new members and some guests. Can I ask all those people for whom this is the first meeting they've attended, either because they're a new member or they're a guest, can you stand up? Welcome to you all. I think this is very meaningful. It shows that our group is still very vibrant and alive. Right at the very beginning, I didn't think we'd last more than 2 or 3 years and we'd have outlived our usefulness. And I told that to Jeff. He said, oh no, we'll still keep going. But there we are. We have industry partners. I'm very pleased to say we've got a couple of new ones. And our current partners, TMA, Heart Research Institute, the Arrhythmia Alliance and Atrial Fibrillation Association, Avril Morris, a particular shout out to her who's done a fantastic job here. Late breakers. Well, we're going to have Amalfi and the Find AF this year. And our 6th white paper, as you saw, was published today. So that's another element of vibrancy. This paper here, very pleased, is actually a simultaneous publication online today in the European Heart Journal. We switched journals at the moment from Circulation to the European Heart Journal. And I'm very pleased and very grateful to Emma Svenberg, who led this one with John Cam, and all of the 51 other people who contributed. Thank you. Congratulations. I believe this will be another citation classic. And earlier in the year, we had Timo Niranen led the group for hypertension and atrial fibrillation. I think it was a fantastic, I learned a lot. And this year, for the first time, I've asked members to vote on what they thought were the best 3 publications in the last 12 months. There may be a type 1 and a type 2 error here. I'm not sure, because the sample was relatively small. However, what I did was take those which got at least 3 or more votes, and those 3 were the AF Burden consensus paper of Wolfram Dörner in Europace, the Stroke Stop 2 study I mentioned today, Dr. Kem Gudmundsdottir in Circulation 2024, and the GUARD AF paper, Renato Lopez. We've spoken about it earlier. Those with 2 votes, and I'm handing out the list, so you'll see the full list, included the AF Burden in GUARD AF from Danny Singer, the Lancet Regional Health EU for systematic screening for AF and with non-invasive markers, Wahab et al. And Chris Gale, one of those, it was the senior author, had 1 vote each. My particular favourite, which I've said to Danny before, was the AF Burden in GUARD AF, only for the one point that the very first patch that was sent out, that was applied, if you had AF on that, you had nearly always AF for the whole duration of the 14-day patch, which means that if you do a single time point screen and you get it positive, you almost certainly have persistent AF or very high burden AF. I think that was my exciting one. But please read through those. And as I saw when I went to this great David Hockney retrospective in the Fondation Louis Vuitton, it's about to finish, this painting really led to my thought process. It sort of married, and it just rang all sorts of bells. Less is known than people think, which is the motto of this organisation. We are always increasing our horizons. I thank you very much for coming. I thank all the members, and I thank all of our industry partners.
I think it's time now then to move on to the next session. It's entitled The Link Between HFpEF and AF. Jeff Healy and myself are the chairs, and we have two talks followed by a group discussion. The first talk will be given by Greg Lipp from Liverpool, and he's going to talk about studies and trials on AF and HFpEF. So over to you, Greg.
Thanks very much, John, and great to be here. And Ben, again, congratulations on bringing us all together again. It's a very exciting meeting, and very much looking forward every year to have this, and long may it continue. So I've been asked to give, in 7 minutes, a total overview of atrial fibrillation and heart failure, particularly focused on heart failure with preserved ejection fraction. I noticed that Jeff was following me with EP considerations, where some of the more exciting clinical trials are coming. So I'll briefly touch on them, but hopefully Jeff can cover the electrophysiology aspects of this. So here are my declarations. I'm not going to read every line because they're not very interesting. But nonetheless, why the interest between heart failure and atrial fibrillation? And I think we know this bidirectional relationship, and I think there's a number of studies clearly reporting on the association between heart failure and the progression of the arrhythmia. And this is just a selection from a recent review looking at the progression of atrial fibrillation, some of them defined in rather heterogeneous ways. Paroxysmal to persistent, for example, and then whether heart failure is associated with atrial fibrillation progression. Clearly, again, with the progression of atrial fibrillation, if you look through a number of these studies during the period of progression, that is when seems to be an association with increased major cardiovascular events. Now, we're talking about something quite common. Now, this is from the Get With the Guidelines Heart Failure Registry. And I suppose a number of points in this rather busy visual summary. Well, firstly, if you look at patients with heart failure with mildly reduced or mid-range, as whatever terminology we used just now, or heart failure with preserved ejection fraction, we're talking about 50-odd%, where there could be the prevalence of associated atrial fibrillation. And if atrial fibrillation is present, no big surprise, in this group of patients with mildly reduced or preserved ejection fraction, there's much worse outcomes, whether it's related to all-cause mortality, readmissions to hospital, heart failure admissions, stroke, and bleeding, and secondary bleeding. So worse outcomes. Now, in terms of drugs, you can see the most common drug in terms of rhythm control was amiodarone, and this is related to some of the interest into whether or not this is also particularly related to some of the complications associated with atrial fibrillation. But in the interest of time, I'm not going to go to some of that detail because this was in relation, for example, to the EAST trial where amiodarone was clearly had a signal there. Nonetheless, in terms of clinical studies, in relation to AF and heart failure preserved ejection fraction, do we need to differentiate heart failure preserved ejection fraction, heart failure reduced ejection fraction? Well, if you look at the Swedish Heart Failure Registry, so clinical registry data here, well, actually, atrial fibrillation was more common with increasing ejection fraction. And in terms of clinical characteristics, there was broadly similar phenotype or in terms of clinical characteristics between heart failure preserved ejection fraction, mid-range ejection fraction, and those with reduced ejection fraction. And I think this was an interesting bit from here. Now, hopefully this pointer thing works. Oops, oh, I switched it off now. Sorry about that. Let's try again. Yeah, there we go. So I think the interesting bit is here. If you want to look at the outcomes in terms of atrial fibrillation and, for example, mortality according to ejection fraction, whether it's preserved ejection fraction, whether it's mid-range, or whether it's heart failure reduced ejection fraction, look at the adjusted hazard ratios. They're broadly in the same ballpark there, approximately 20% worse outcomes, irrespective of how you categorize them. But you could say ejection fraction, after all, is a continuous variable, and whether you neatly compartmentalize into preserved, mid-range, reduced ejection fraction, well, I think you can see whether patients neatly stay into those or whether or not they change over time. Now, that's not a new story. This is a rather old study we published from the Loire Valley Atrial Fibrillation Project. We were looking at stroke, we're looking at stroke thromboembolism and mortality. And as you can see, we're rather crudely defining it on the definitions of the day. Heart failure reduced ejection fraction on the basis of the ejection fraction, 50%, compared to heart failure preserved ejection fraction. As you can see, with regard to the event rates, that was broadly similar between reduced ejection fraction and those with heart failure preserved ejection fraction. So irrespective of ejection fraction, with the artificial cutoff 50%, similarly impacted on stroke, thromboembolism, and death. Now, more contemporary data in terms of progressive heart failure. This is comparing a group with preserved ejection fraction or those with reduced ejection fraction. Well, as you can see, in terms of the presence of atrial fibrillation, these patients did worse. These are the patients with preserved ejection fractions. If atrial fibrillation was present, you can see the hazard ratios there, 2.5-fold, compared to those with reduced ejection fraction. Irrespective of AF, they did just as bad. Now, in the previous session, you heard a lot about atrial cardiomyopathy, so I'm not going to go into this area, whether or not it's the mechanism, why this is leading on to this bidirectional relationship. This is a consensus statement of the Heart Failure Association, and in a sense recognizes the continuum, whether it's from the healthy atrium to the atrial cardiomyopathy and to so-called atrial failure, which I think is a nice way to look at this. As you can see here, there's various ways to quantify this. Again, I'm not in the interest of time, I'm not going to go through all of this, but I think the important thing is you'll see here comorbidities. So whether or not the atrial cardiomyopathy is in a so-called entity which is there. Well, it could be there, but you can say also whether it's the aging bit was discussed in the previous session, whether or not it's just the sort of cumulative aspect of the underlying comorbidities, which of course doesn't stay static, it changes over time as well. Now, in the European Society of Cardiology Council on Stroke and the Heart Failure Association and the Working Group Thrombosis, we were very interested in this because clearly the interaction of heart failure with or without atrial cardiomyopathy, with or without atrial fibrillation, that's clearly the interaction leading on to that potential risk of thromboembolism. Now, I briefly mentioned EAST-AF, and perhaps that would be, well, the man to ask us in the room. You can certainly look at this in relation to the impact of early rhythm control in patients with atrial fibrillation and heart failure. In panel A is the, in panel A is the overall cohort there. As you will remember, this 21% advantage by early rhythm control in recent onset atrial fibrillation. Now, this was divided into reduced ejection fraction, mid-range, and preserved ejection fraction. Now, the p-values for interaction are not significantly different, indicating that was suggestive of similar benefit across. Looking at the Kaplan-Meier curves, I think that's clearly an advantage here in the reduced ejection fraction. When you come to the other two, particularly the preserved ejection fraction, can't say the separation is as impressive as was to see the others. Nonetheless, statistics is what you see. P-values for interactions, I mentioned, not significant. So just to finish off, what about if you're dealing with AF and heart failure, what about the impact of catheter ablation? So this is a systematic review and meta-analysis looking at ablation patients with AF and heart failure with preserved ejection fraction. And I think the message is in the red box. With heart failure preserved ejection fraction compared to those without heart failure, there was no real difference in atrial arrhythmia recurrence, no difference in stroke, no difference in cardio tamponade. And actually, if you compared the heart failure preserved ejection fraction versus heart failure with reduced ejection fraction, there was no difference in any of those either by the impact of trying to treat the rhythm. If you're looking at, this is a more recent meta-analysis, efficacy and safety of catheter ablation for AF and heart failure preserved ejection fraction. No difference again in the hard outcomes of heart failure admissions, all-cause admissions, and all-cause mortality. I think the main benefit with catheter ablation, no surprise, is this this freedom from recurrence of atrial fibrillation with a catheter ablation group. Now, we talk about AF and heart failure very much as a sort of isolated things, but they're not. They are interrelated. AF management is more than anticoagulation alone. Heart failure management is more than the 4 pillars of the different drugs. I think it's important that we are moving towards this holistic or integrated care approach management of patients with chronic long-term conditions. And this is the sub-study from the MARFA trial. This was comparing the holistic integrated care with the ABC pathway compared to usual care in a prospective cluster randomized trial. And I think the important bit is to show that irrespective of the presence of heart failure, no heart failure, p-values for interaction are not significant for the primary outcome: stroke, thromboembolism, death, and hospitalizations. In terms of bleeding, p-values for interaction is not significant either. What we did see was with integrated care, there was greater detection of things like recurrent AF and acute coronary syndrome. But because with integrated care, there was an alert going into the centers, so the patients attended, and then they were picked up much more often. So let me conclude in terms of the studies and trials, heart failure, preserved ejection fraction AF. I think it's important to re-stress again the left atrium is important in the pathophysiology and the association of heart failure and preserved ejection fraction. And there's this continuum from healthy atria to atrial failure, as highlighted in the recent position paper. There's various mechanistic reasons that has been covered elegantly in the previous presentation. AF is associated with worse outcomes in heart failure, preserved ejection fraction. And the final thing really is the management of AF includes mitigation of stroke risk, rate and rhythm control, and the comorbidity and lifestyle management. It's not just anticoagulation alone. There's this holistic integrated care management based on evidence, not eminence. Thanks very much.
Thank you very much. And our next speaker is Jeff Healy. Jeff Healy's from Hamilton in Canada.
Thank you very much, and always nice to follow Greg, who has presented all the relevant history. So I want to make a few very, the mic might not be perfect here. I want to make a few very high-level points here when it comes to the EP perspective on heart failure and atrial fibrillation. So here's the first point. Why do people die when they have atrial fibrillation? And we all know this, but we don't live this or practice this necessarily. So we focused a lot, even in this group, right, around atrial fibrillation, stroke prevention through screening. But you can see the red and the yellow bars. These are different regions of the world, and clearly more patients are dying from heart failure anywhere on the planet, atrial fibrillation patients, that is, compared to stroke. You certainly see a gradient in the more expensive healthcare systems, Western Europe, North America. That sliver of stroke gets relatively small. When you go out into Eastern Europe, Africa, and the Middle East, stroke becomes larger. But in all cases, it's the leading cause of death. And you know, we've known about this for a long time. It's just a harder nut to crack in terms of delivering interventions to reduce that outcome. And I think this is where we're all poised. And I think the first thing I'd like to convince people is this should be a focus of our research, but also of our clinical care. So we got interested in this. You know, I wanted to kind of frame this a little bit like screening. You know, the pacemaker detected world, you know, we fuss over, you know, stroke and embolism. That was the topic of NOAA and Artesia. The reality is, if progression of atrial fibrillation, subclinical in this case, is a decent predictor of stroke with a risk ratio of 2.5. For heart failure hospitalization, it's a much better. It's 4.5 to 5 times, and this has been replicated now several times over. So whenever patients go from having a little bit of device-detected atrial fibrillation to a lot, their risk of heart failure hospitalization goes up substantially. So we're actually even better at predicting heart failure. Now, it comes with a twist, right? Because if you forget about low ejection fraction patients, and you have a patient in front of you, and they have atrial fibrillation and HFpEF, what's what? Okay, we think about, oh yes, they come in with palpitations and tachycardia, but that's not how all atrial fibrillation presents, right? You look at the guidelines, short of breath, unable to do activities, exercise intolerance, these sort of things. That can sound an awful lot like both. And we try to drill into this. So in the spirit of getting into some of the EP, these are device data here using multi-sensor technology inside of implantable defibrillators. And I'll show you what that exactly looks like on the next slide. But what they looked at was when patients had atrial fibrillation picked up by the device, and these are the multi-sense trial data. If they were long episodes, you can see starting at time 0, short episodes under 24 hours or no AFib picked up by their ICD, the incidence of heart failure becomes quite impressive. So here, again, this is a reduced ejection fraction population, but about a 25% incidence of heart failure after a very short follow-up of less than a year. So very interesting. And what, if I can go the right direction, what these detectors we're seeing, this is the heart logic for those in the know, multi-sensor technology looking at things like thoracic impedance, intensity of the first heart sound, presence of a third heart sound. These are all picked up by the implantable defibrillator. And you can see that some of these heart failure indices begin moving before this line in the sand, which is where the atrial arrhythmia burden, this is atrial arrhythmia burden here, jumping up at this line. And you can see there's a chicken or egg thing. Sometimes the heart failure sensors alarm first, and then the atrial fibrillation develops over the ensuing days. And in other indices, and these are just the average, the heart failure indices change after, a good one example here is the S1 intensity. Obviously, that's going to go down when the heart is fibrillating. So, there is this back and forth of, is the AFib driving the heart failure? Is the heart failure driving the atrial fibrillation? And again, something we've known for decades. Alessandro Capucci used to put out a meeting every year in Bologna, which is on this topic of atrial fibrillation and heart failure. We had a lot of great talks. But again, part of the issue is, in the EP perspective, we really don't see atrial fibrillation, we don't see heart failure as an important component of care yet. I think that needs to change if any of this good work wants to find an impact on patient outcomes. So my world, I see a lot of patients with defibrillators. These are Jeannie Poole's data, looking at what happens after patients have ICD shocks. I'll draw your attention here, though, inappropriate shocks. This was largely due to atrial fibrillation, and there's about a 2-fold increase in mortality if you have an inappropriate shock. Now, people say, well, it's the harmful effect of the shock. It actually isn't, and it's really the substrate that led to the atrial fibrillation, as it turns out, that is more likely to account for this problem. We give patients beta blockers, we consider all sorts of reprogramming changes, but these are a reduced ejection fraction population. What we don't ask, even when patients have appropriate shocks, is what do we do for that underlying substrate to alter things. So we should be focusing on it in the presence of atrial fibrillation. It's actually even more true for appropriate shocks for ventricular tachycardia, right? If you have a shock for ventricular fibrillation, a high percentage of these patients are dead within the year. And so it is, and they're dying from heart failure, not from storm. So we really, again, neglected in our day-to-day practice, whether it's the clinic, AF clinic, or whether it's the device clinic, heart failure just doesn't bubble up. And because Greg alluded to it, and I'm having a real hard time here today, that is, trials have been done, right? So there's a clear distinction to be made between the heart failure with reduced ejection fraction and preserved ejection fraction, right? We have several good studies. Castle AF is just one, RAFT AF is another, where we see significant reductions in hard clinical outcomes when we control rhythm with ablation here, and just look at the primary outcome reduced by 38% here, death by any cause reduced by nearly half, heart failure hospitalization reduced by about the same amount. So very impressive results, small study. But when you look at the limited data in the HFpEF population, we see less encouraging results. So the RAFT-AF trial did have a preserved ejection fraction cohort, and although they showed benefit with reduced ejection fraction to ablate these patients, this was not seen in the preserved ejection fraction. Now, we'll have more data coming. We'll have many of these patients in the East High trial. We have the purpose-designed Castle HFpEF trial, which will be starting soon. And, so we'll have additional data. We have very little data on anything else in terms of altering outcomes in the HFpEF space specific to atrial fibrillation, right? So we have an inkling that drug therapy can work in HFpEF. It's a much smaller list of medications, but SGLT2s and possibly mineralocorticoid receptor antagonists. But again, there's not a lot of data looking directly at how to improve outcomes with this. So I guess the focus on EP, I would argue, needs to shift, that heart failure is the most important bad thing that's going to happen to our patients with atrial fibrillation. And even meetings like this, we should be giving greater airtime to discussing this outcome. I think EP physicians on the clinical front could be more focused clearly on the things like guideline-directed medical therapy for HFrEF, but as we come into HFpEF with the smaller number of therapies available, I think that should also be a focus. Rhythm control, again, I think this is where we are with clinical trials now. We know that this seems to work quite well for reduced ejection fraction, and we're about to learn if we can replicate those benefits and those preserved. So thank you very much.
Thanks very much, Jeff. Perhaps Greg, you'd join us on the stage. Questions? Yes, Giuseppe.
Congratulations to both the speakers. Jeff, you reported in a very nice meta-analysis that AF ablation improves the outcome in heart failure in patients with reduced ejection fraction, but there is no evidence of benefit when there is preserved ejection. In your view, is it a matter of fewer studies, fewer patients enrolled, or there is a pathophysiological link? Because the link between diastolic function and AF exists, so the benefit should be considered, but is not proven.
Yeah, for sure. So first of all, power is always an option, right? It's a lower risk population, limited studies, limited number of patients, so absolutely could simply be underpowered. Second, was the intervention well delivered? Well, it was fairly well delivered. It delivered, it was the same raft as a good example. It had two arms. We did measure burden over time. It went dramatically down, and we got a big effect with reduced ejection fraction. So I don't think it is inability to isolate pulmonary veins or ablate atrial fibrillation. But the third thing is, we saw this with some of the drug trials in HFpEF, like TopCat. Defining the phenotype is tricky, right? So do you actually is that patient actually a HFpEF patient, or is that just an AF patient? And these can be harder to define. We've struggled with the enrollment criteria, so they're BNP based, but of course it depends. If you've had a lot of atrial fibrillation recently or you're older, the BNP thresholds may be different. So I think there's some of that in terms of patient selection that might be playing. But HFpEF is one of those disease entities like dialysis where good therapies go to die, right? Like it's a very hard needle to move, HFpEF.
So,
okay, go ahead.
So I don't think, just to add to that, and if you're planning this as a future position paper, to think about this, because we tend to categorize patients: heart failure reduced ejection fraction, heart failure preserved ejection fraction, and we give a cutoff of ejection fraction 50%. So are you going to tell me that 49% is going to be pathophysiologically any different to somebody who's got 51% ejection fraction? Probably not. It's a continuum. And many of the trials or the studies that have looked at this have looked at it at one time point at baseline, entered them in the trial. But we're dealing with progressive disease. The rhythm is progressive. Heart failure is progressive. Comorbidities are progressive. Age is progressive, I'm afraid. So something to think about.
Can't you keep it down? I'm just looking for that fountain of youth. Obviously, I'm missing.
We like age to progress.
Working on it.
Working on. Oh, great. Can I just ask one question, a quick one, and that is, in HFpEF, AF is actually one of the diagnostic criteria. Why does that give you any clue as to what chicken and egg issue?
Well, just from the studies that I presented, I think it's bidirectional. And secondly, if very often AF is without symptoms anyway, so they may well have had heart failure preserved ejection fraction associated with aging, comorbidities, and getting silent AF, and we don't know when it's the first time they detect it when it's first presented very often with a complication associated with heart failure. And the other way around, patient with atrial fibrillation, they get followed up, they get assessed, very often get an echocardiogram, and they get assessed, well, ejection fraction is normal, so it must be, since they're breathless, must be heart failure, preserved ejection fraction. So I think there's this diagnostic conundrum there.
I think the one good thing, though, with ablation is it may actually rekindle our interest as electrophysiologists in heart failure as an outcome. I mean, you don't have to talk very long to an EP to convince them to do an AF ablation. This is something we'd like to do. And again, it may rekindle our interest in the outcome, which I think would be a major benefit to the patients.
That's a really major contribution that you've made. I think we keep forgetting about HF as an outcome.
Question from Paulus.
I think a lot has been said. Just two quick comments. One, when you look at early AF, so for example in East AF Net 4, I think we had pretty much exactly 100 strokes, and we had about 160 heart failure events. So that relation that you showed in that Lancet paper, I think it's probably still a bit more equally. So it's stroke and heart failure that we need to be concerned about. And the other comment that I have is regards how do you diagnose HFpEF, and I think you can see by the number of debates on what is HFpEF how difficult it is, and yes, AF is a component in some scores and not in others, and for a debate you could even take the position that HFpEF doesn't exist, it's always AF, and then of course you can take the opposite position that AF is always a consequence of HFpEF. So I think the blurriness of diagnosing HFpEF is a challenge.
Yeah, the only thing I'd counter to that one point is EAST is a clinical trial with selection. Those data are ER-based population level registry data.
Yeah, but I would think when you look at the beginning of the AF history, I would think there is a time trajectory as well. So that, I mean, clearly in the end we're all going to develop some form of heart failure. This is like we are all getting old, so we'll have heart failure.
But John and Emma, you made that point, sort of heart failure was a very big, and heart failure hospitalisation was a very big thing you mentioned in recently diagnosed AF. I think you haven't forgotten that, and we haven't forgotten that.
Certainly not, no.
It's also just to add to this comment, just a rather old paper from the Glasgow Heart Failure Clinic, probably reflecting my age, but anyway, from the Glasgow Heart Failure Clinic, referrals for breathlessness due to heart failure very often actually had normal ejection fraction, but actually was obesity.
We talked a lot about the bidirectionality between AF and heart failure. Interestingly, most of what you've discussed is the direct management of AF, not the management of heart failure.
Sure.
And as you know, there are an increasing number of trials in heart failure demonstrating significant reductions in atrial fibrillation. The quality of that AF data is probably questionable to an extent, but why are we not talking more about that side of the equation?
Yeah, no, I believe we should, and this is what I was talking about when it comes to the device clinic. We do have medical therapy. The renin-angiotensin system antagonists seem to reduce atrial fibrillation to at least modest to moderate effect. Beta blockers seem to have little direct effect, and SGLT2 inhibitors, despite very small amounts of data, appear very promising as a therapy you can deliver both with reduced and preserved ejection fraction to prevent atrial fibrillation. So again, the big challenge there is getting EP docs to open up their prescription pad and say, okay, we're going to deliver this therapy in the face of this atrial fibrillation. We're good at anticoagulants, but we just, I give a little bit of an argument because we just haven't been focused as much on this.
Do you think the heart failure drug company representatives should be visiting the EPs a lot more?
Yeah, well, again, there is an opportunity here with these multi-sensors, right? Picking up whether it's Optival in the Medtronic systems or HeartLogic in the Boston or other systems where all of a sudden we could become interested. The implementation science and some of the work like with Adrian Hernandez down at Duke it's a tough sell to convince EP docs that this is important.
Yes.
And yes, that's the EP bit, but I think with chronic long-term conditions, very often elderly, very often multimorbid. I did show the MAFA trial. We also showed that in the Miracle AF trial, 2 independent trials with holistic integrated care management. One of the secondary outcomes is actually a significant reduction in heart failure hospitalizations. So these are, if you deliver and not think about AF as only anticoagulation, forget about everything else. Don't think about heart failure as only the 4 pillars of heart failure management. You think about the whole patient, not just the bit of the patient.
You bet.
Well, I think we've probably consumed too much time, Ben. I think we're 10 minutes late according to the program. So when would you like us back is the question for you.
Well, I think we should, we have an afternoon tea. We should try and come back. It says 3:55, I guess 4.
1,600 hours.
1,600.
No, it's totally true. Like it's
yeah. So first of all, let me introduce my co-chair in this, who needs no introduction. That's Wang Jiguang from Shanghai, who will co-chair this session. And the very first part of it is going to be combined screening for hypertension and AF. This was one of the big projects that we had. Jiguang, if you can.
Okay. Thank you, Urban. It's a great pleasure for me to chair this part of the meeting. My co-chair, Professor Alta Scooter, has something to do, and she left a few minutes ago. So let me first invite Professor Neil Poulter to give the first presentation entitled From 2022 to 2025 Progress so far. Huh? So shall we have something different?
No, that's it. So Neil and this group have a partnership, and we have a number of people from MMM here, and this partnership has led to really great things. So I just wanted to say it's great to have you with us, and it's great to have the group with us, because we have learned a lot, and I think together we can do a lot more.
Thanks. Yeah, actually we have been working in the main measurement MANS project since almost 10 years, and since a few years ago we started also atrial fibrillation sequencing in combination with hypertension sequencing in a very large number of people. So please, Neil.
Thanks very much. Ben, Jiguang, John, ladies and gentlemen, I'm delighted to be here. Thanks very much indeed for brokering that, Ben. So my name is Neil Poulter. I'm Chair of Preventive Cardiovascular Medicine at Imperial College. Just for those who don't know what May Measurement Month is, it's opportunistic blood pressure screening program initiated in 2017 when I was president of the International Society of Hypertension, and the main aim was to raise awareness of high blood pressure around the world. Given that about 50% of people with hypertension don't know they've got it, if we're trying to get the control rate up to 50%, we've got to improve the number of people who are aware of the problem. So we set up screening sites all around the world with trained volunteers, and we've been in over 120 countries so far, and we screened in the first, between 2017 and 2024. There wasn't a campaign in 2020 because of COVID, but we've screened over 7 million people. And the history was that Ben contacted me in 2021 and said, why don't we screen for atrial fibrillation as part of the MMM thing? And we put our heads together and got that going. And we did some pilot studies in 3 countries, Philippines, Vietnam, and UK, in a couple of months as you realise, isn't in May, in 2021. And then we went on slightly more formal in 2022, 2023. And you can see reasonable numbers. I beg your pardon. See if I can do it here. I can. Reasonable numbers in 2022 and in 2023 screened for atrial fibrillation and blood pressure at the same time. So at the bottom of the slide, in those 2 years, we've pulled these data together, and that's largely what I'm going to show you. I don't know if I can go back, can I? But how do I do that? Go to the one underneath. Oh, yes, easy, right. So in those 2 years, we included about 17 countries, and the AF was detected using the Alive Core or Omron Complete or M7 devices. and known AF, which I'll refer to now and again, was those who said they self-reported previous diagnosis of atrial fibrillation. So to sort of formalize this within the MMM protocol, here you see what we did. We had an atrial fibrillation sub-study for those countries, and within some of the countries, some of the sites, pop-up sites within the countries, took part in the atrial fibrillation bit. The key points were, depending on the ethics, was variably required around different countries. We used the complete, either the M7 or the IntelliSense devices more recently. And the target age group was 60 plus. We agreed that with Ben. And as you'll see, everybody cheated and they did all sorts of ages. But it gave us, we've got all the data on that. So it's interesting. It shows there's a sort of age relationship, not surprising. So we had a usual questionnaire, which we normally dish out, about 30 questions, and we added some atrial fibrillation specific questions. And in those that we detected atrial fibrillation, they were advised of their condition. They were given written information about the causes and consequences of atrial fibrillation, and they were referred to the relevant facilities for confirmation of the diagnosis and management if required. And in order to facilitate this, because this is all anonymized, we produce these unique reference numbers to facilitate an anonymous linkage, which would allow us to have some degree of follow-up. So this is the typical questionnaire sort of thing we used in 22, 23, 24. And the questions up here are you currently taking medications for, and C was warfarin, anticoagulants, aspirin, we asked that. Then halfway down, have you ever experienced or been diagnosed as having, and we put irregular heartbeat, which clearly was non-specific, but was a problem that many people around the world wouldn't know they got atrial fibrillation even if they had. So we use that, and then down at the bottom here, let me just see if I can do this. Down at the bottom there, we just, on the blood pressure machines, was the pulse recorded as regular, and then we asked, was atrial fibrillation detected in the current assessment? And have you ever been diagnosed as having atrial fibrillation by a health professional before? And what device did you use to detect your atrial fibrillation? So that was added into our routine questionnaire. And we produced a patient journey, which I won't bore you with, except to say we began at the beginning with the usual MMM screening by protocol, and then we went on to say, pretty much as I've described, people if they were also screened for their atrial fibrillation, and then they were given information sent off, and they got their URN, these numbers, which kept the whole thing anonymized, and we were able to follow them up. Except, as you'll see, that has been the big weakness of the whole thing, is our follow-up, our link with the cardiological follow-up after MMM. So here's the results from, and this is being shown in a poster, moderator poster tomorrow. Tom, who's the guy who does most of the data analysis for us, was to present this, but he's first author, and along with the atrial fibrillation scheme and the MMM lot, we've got this poster together, and this really summarizes the results. Top left, 13,500 participants had joint AF and BP screening in those 2 years. Mean age was 50, as I said. The original target was 60 plus. 56.3% female. The majority were from the East and Southeast Asia, about a quarter were white. And then top right, the overall atrial fibrillation detection rate was 1.9% of those screened. The rate was 1.2% if you were below 60, and 3.3% amongst those who were 60 and above. And of those who were detected, about half had no atrial fibrillation. Okay? So then down at the bottom, just focusing a little bit on the hypertension and relationship to atrial fibrillation. After standardization, I don't know if this is perhaps clear, after standardization for age and sex, just under half of those with AF detected had coexisting hypertension, whereas in the general population, the screened, it was only 34% without AF had got hypertension. 2.6% of those with hypertension had AF, so turning it around the other way. And in those over age 60, AF was detected in 4.1% of those with hypertension versus 2.1% in those without hypertension who were over 60. So big difference there. The association was clear with hypertension. So now just to come back to things that I think everybody realized and unsurprising, what you see there is the percentage amongst the women detected on the third column, detected to have atrial fibrillation by age group. First column, the age group, 10-year age bands. And what you see here clearly is this increase by age with 10 years. There you go, up to 4.2. That's missing age. And overall amongst the women, 1.6. But by age band, you see here this clear age effect. And the same thing is true when you go to the men. A clear age effect right the way across the age band. That's 70 and above, I think. Yeah, 70 above. And the other thing, if you just compare the women overall and the men overall, more of it about in the men and increasing age effect. No surprises. Then the other factors that are associated with atrial fibrillation, well, we've dealt with hypertension. That's at the top. You can ignore the rest, really, except to say having raised blood pressure even on treatment, or rather not on treatment, the raised blood pressure, the risk was higher. This was your odds ratio of having atrial fibrillation detected. Okay? Increased likely detection with diabetes, with a previous MI, with previous stroke, and previous heart failure. And in light of what we were talking about earlier, the heart failure result is not surprising. If we then look at booze, basically 1 to 3 times per month, so one drink less than once a week was, if you take that as the baseline, more booze than that was associated with more atrial fibrillation. Current smoking and adherence to physical activity guidelines by WHO seem to have no association. Let me just highlight that. These two seem to have no association, smoking and adherence to physical activity, no association with your likelihood of being detected as having atrial fibrillation. But then the education are the two things at the bottom, and those with the least education were quite increasingly likely to get picked up with their atrial fibrillation. And then finally, body mass index. The usual thing here, that's 4 grades, you might call the top grade underweight, and then taking this as the sort of normal category, normal category there, then you see as you get heavier, you see that, which links in with the blood pressure, which links in with the heart failure. That sort of J effect that you see with weight is something that occurs with lots of outcomes. The very thin do badly in many areas. So this is sort of hot off the press, and I thought, I haven't gone through this massively carefully myself, but what it shows is the number needed to screen to detect one case of AF using the CHADS VA score group. And on the left-hand side here, you see the all scores. So it's all scores combined, then those with 1 and above, 2 and above, 3 and above, and then it shows the percent with atrial fibrillation for those under 60 on the left and over 60 on the right. And it's the same sort of story. Let me just go through that. So percentage with AF, with increasing CHAD-VAS scores, CHAD-VAS score I should say, that's amongst those under 60 and those with AF CHAD-VAS score, the increases you can see there in those over 60. And then the last two columns focus on the numbers needed to screen to detect one participant with atrial fibrillation. First of all, under 60 and then over 60. And the numbers are really quite small. I thought surprisingly small. And the difference is clearly there for those over 60 versus under 60. But you see the trend all the way down. And the numbers needed to treat are to screen, I beg your pardon, are really quite small. I won't go into that except to say that 2024, we've had another screen there. We've got 7,000 detected. We're going to review these data. There's a big input from China that year, but 15 countries in 2024, but won't want to go on any longer about that. There we go. So what's happening now? Well, our big problem is there's a disconnect between our finding people with AFib in MMM and linking them up with the AFib screen representative in these countries. 15 countries going in 2025, and we don't seem to be able to link them up. Now, we had 2 meetings, webinars with meetings from MMM, the national leads, and the AF screen people in the countries who are involved with this, sat them down and webinars and gone through the plan, the patient journey, what the idea is that they are sent to the AFib screen section and then etc. But we're failing to make that happen. In this year, we've used the M6 IntelliSense, care of Omron. And as I said, we've had a couple of meetings linking the MMM and the AF screen leads, trying to drive the link up. But so far, certainly it didn't happen effectively in 2024. And we're hoping it'll be better this year, but the data obviously are not in yet. We ran a workshop with Omron to demonstrate the use of the IntelliSense for everybody involved. As I said, this is in progress at the moment with 16 countries. And that's basically it. Thank you for your attention.
Thanks very much, Neil, for showing us the data I hadn't yet seen. And although there are no surprises, I think there are surprises. And there's no surprises in the fact that we are really struggling, not just in this place, but having a proper pathway to action. In our very first meeting 10 years ago, I remember Giuseppe Loriani said, well, if we have consumers or if we have this done in the marketplace, how are we going to get these people into a pathway? That is something we haven't yet crossed. And it's not an easy thing to do, but we should work on it. But I think looking at the scope of the problem should make us think maybe we need to do it a bit more. So without further ado, I'm going to ask Timo Niranen, who again is a sort of general renal physician with an epidemiology interest, who works in Finland and who led our hypertension and AF paper in which we recommended that we do combined screening and also talked about how we might implement it. So this is now to discuss a little bit what happened after that white paper or what happens, and then we'll have some group discussion. Thanks, Timo.
Okay, thank you for the invitation. Thank you for entrusting me with the white paper that was published. So thank you all the co-authors and especially Ben. So this was really a topic title I did not like at all, because who am I to say what we should do? So I'm really expecting forward to the discussion. So I'll be very fast and just mention a few low-hanging fruit that might be done with some smaller group of people who are particularly interested about the associations between hypertension and atrial fibrillation. So this was the white paper, and actually we already in the paper said that these things should be important to address in the future. Well, naturally some of these demand a lot of money and some are not that important, but maybe I'll just pick up a few of these things just to begin the discussion. So what is the optimal BP target for primary prevention of AF? So in basically all hypertension guidelines, the target BPs have gone down, but not that much is known about what's the optimal BP target for primary prevention of AF. So after SPRINT, there have been a lot of other studies published on what's the optimal target for treating blood pressure, and this meta-analysis has the end point of cardiovascular disease. So, but for atrial fibrillation, the only data are coming from SPRINT that did like a subgroup analysis for atrial fibrillation published in 2020. So they barely got for a hazard ratio of 0.74. I think the p-value was 0.04 for a blood pressure target of 120 instead of 140. So that's a low-hanging fruit at least? Would there be a chance to perform a review and meta-analysis based on all published data by contacting these trialists? That's one option. Then there's what's the optimal method for simultaneous screening for hypertension and AF in patient-initiated screening? Most likely, as we sort of suggested in the paper already, probably the automatic devices that would include an ECG instead of devices that just sense the irregular heartbeat would be better, because then you would have a diagnosis immediately instead of the person having to go to the MD or technician to get their ECG done. However, something that I just realized like 2 days after the paper was accepted for publication that we didn't mention at all, like how should we measure blood pressure in atrial fibrillation patients, because this is actually something that is quite unknown after all these years. So oscillometric blood pressure monitors have taken over in all parts of the world. However, the situation currently is that there's very limited data exists to suggest that some automated devices can accurately measure systolic but not diastolic blood pressure in the presence of atrial fibrillations. And even the guidelines do not know what to do with these patients. And my personal experience at the clinic is sometimes, especially if the ventricular rate in these patients is very high or very low, then there can be like a 20-30 millimeter mercury difference between oscillometric and oscillatory measurements. But the guidelines say, ESC says oscillatory method is preferred, ESH says use of automated oscillatory method should not be excluded, and the AHA-ACC hypertension guidelines say nothing about this. So one option might be to do some kind of joint meta-analysis, review position paper with perhaps ISH. George is here, president of ISH, on blood pressure measurement in AF. So how we should measure, because in some AF patients we get the blood pressure measurements with the automatic monitors that are really just wrong. And it's, at least in Finland, most physicians don't even have access to the oscillatory monitors anymore. Then finally, screening. Well, we already fantasized to do this interesting screening trial with simultaneous screening of hypertension and AF. Unfortunately, this requires a lot of money. At least with Renate, we've been looking for funding options for a trial like this. So basically, it would be control or no, which would be no screening, and then intervention arms for blood pressure screening only, or AF plus BP screening, or just 2B. That's another option. However, there's some limitation. The current AF screening trials, they've been limited by the low yield of detected AF cases. They may have enrolled individuals with too low overall stroke risk and therefore suffered from small number of preventable strokes, or they have screened only for AF despite hypertension being the leading risk factor for stroke. So something I've been doing in Finland, or trying to do, because we are a small, poor country, we need to save money. So I'm suggesting a trial, and we have a cohort of 500,000 people who have been genotyped. So in addition to the age threshold, we would look at only recruit people with a genetic risk that would be, or the polygenic risk score that would be the upper quintile. So this would mean a lot less people needed for the trial, because people in the lowest 5% have probably about 1/5 of the risk of stroke than those in the highest 5%. Then the optimal intervention also, which would probably be simultaneous screening for hypertension and AF with ECG, and also to save costs, looking at optimal feasibility or costs, which means electronic contacting, consenting, and follow-up of participants, which is at least possible in Finland. Only thing I'm missing is the money. But these were just some thoughts of mine. I would be extremely happy to hear what the panel thinks, how we should continue on the joint hypertension AF road.
Please stay here. There's two questions that you've raised and one that you've raised. I think three things we should talk about is that pathway to care, which is a problem for all of us, but particularly if you're concentrating on hypertension, how do you get the AF dealt with when you find it, number one. Number two, the studies that you've been talking about. And number three, we could do the easiest one first, and that is everyone in the audience who is not a hypertension expert happy they know how to measure the blood pressure in someone with atrial fibrillation? I heard we have the expert on measuring that. That's also who's a member of this organisation, George Stelgiu, who's also the president of the International Society of Hypertension. Perhaps I could ask him to make a comment. How should we, as mere mortals who are general cardiologists or electrophysiologists or general physicians or general practitioners, measure the blood pressure in someone with atrial fibrillation if we don't even have an acoustic device? George? Here he is.
This is a challenging question indeed. For blood pressure, there is one measurement, intra-arterial. Anything else, auscultatory, oscillometric, are not measurements. They are estimations. So if you want to go for measurement, even auscultatory is not good. It's not telling you. It's quite different than intra-arterial. So atrial fibrillation is a problem because of the dynamic variability. But variability is not exclusive to atrial fibrillation. If you look at the validation studies in sinus rhythm, almost 20% of people are excluded because of variability. If you go for atrial fibrillation, 50%. So the problem we have is that we discuss about hypertension, and we don't have a consensus on how to measure blood pressure non-invasively. But ISO is working on a standard specifically for these people, and FDA is also interested in adopting something. It's not going to be perfect.
George, what's your best guess now, before ISO comes out with a statement?
My guess is that any measurement struggles, any method struggles in this case. It's the most difficult setting for blood pressure measurement. So I think we know that these measurements have value. What is the value? Not measurement, the prediction. In AF, blood pressure measurements in any method, auscultatory or oscillometric, predict risk. Several studies have shown that. So there are good measurements. How to deal with the millimeters of mercury is something that ISO has to deal with. But the thing that the fact that these measurements have clinical value is proven. They do their job. They predict risk.
That's pretty helpful for us. Any other question on this? There's one up.
I'm just curious. Is it the systolic blood pressure is usually higher or lower than auscultatory?
George?
Because I have a view,
the
but
meta-analysis a couple of years ago.
Timo made a good comment. In hemodynamic stable patients, oscillometric is close to auscultatory for systolic. Diastolic, in these people, they're old people, we are less interested anyway. If you have very high, heart rate, then it's a problem with the oscillometry. Timo mentioned that. And in this case, I don't think 5 millimeters or 20 millimeters matter. In this case, this is an emergency. This patient is unstable. He needs heart rate control. And it doesn't matter if you have accuracy 30 millimeters mercury. You are not dealing with hypertension. You're dealing with a vital sign, in this case, of very high heart rate.
Thank you.
I see it be high. The oscillometric is often high in my clinic, and when we do it manually, it's lower. Now, I don't know if it's because it's the second time we're taking it, and the patient's upset because it was high, and then it's lower, but reproducibly, it's higher.
Neil, did you want to make a comment?
I just wanted to clarify, when George said they're old people, it doesn't matter.
age and we don't worry about it. It's the systolic we worry about.
Thank you for that clarification. Us oldies in the audience are relieved. So we next come to the second question that really you raised, Neil. And I don't know if there are any cardiology people who are working in MMM countries and tried to grapple with how we get the pathway right. Can anyone volunteer? They tried it, they thought about it.
Can I just
Neil?
One of the problems is that within a...
You want to come to the microphone here?
Yeah. One of the problems is a country X takes part. They've got 20 sites in different cities around the country. Okay, and then the cardiology expert, the AF screen person, is in one of those cities, and he hasn't got, well, it's pretty tricky for him or her to set up a cardiology colleague in these other 19 cities to link up with the MMM people. So there's a lot of internal arrangements got to take place, and on top of a busy working schedule, that's tricky for everybody involved. But George, you've been involved with setting it up, I think, in Greece, and Jigwang, you've done it in China. So maybe, I don't know, Jigwang, you could quote how you've gone around it, but the logistics are really tricky.
It's difficult but possible, especially when we are restricted to the elderly people. So we actually did atrial fibrillation sequencing in all those people over 60 years. So it's possible to do it with either the blood pressure monitor or with a levical device. These days you may also use ECGs to do atrial fibrillation sequencing in the population. So it's possible to do it.
Yeah, I think all of the cardiology specialist societies say we need to do an ECG for the diagnosis. So a PPG is not enough, or an oscillometric is not enough. Handheld devices are the easiest, in my view, to do quickly, and you can easily have them in the place where you do the screening. And then at least you've got a diagnostic possibility. How you refer them on is a completely other implementation issue. In pharmacies, I might say it only really worked when the pharmacies had established a link with a clinic, and then they guaranteed that the patient would be seen within a couple of weeks. It's very hard. Implementation is much harder than almost anything else we do in cardiology. So I don't have an answer. One other response, and we should just deal with
a comment about oscillometric devices. They are everywhere. Homes, pharmacies, and these are an opportunity for AF screening. And there is a risk. Think about a patient going to a clinic, having an automated measurement. If you don't palpate his radial artery, and if you don't examine them, he comes with an AF and he goes out with an AF. He went to the healthcare professional, he was diagnosed. So if you're using automated devices, it's a huge opportunity for AF detection. And these devices have very high diagnostic accuracy. Of course, MMM is not ECG, it's blood pressure measurement. Yeah. The diagnostic accuracy is 95%, and it's improving. Now they have algorithms which make triplicate assessment for AF in a single measurement. So I think it's all automated devices, when they are using old people, hypertensive people, they must implement an accurate algorithm.
Yep. So there's a lot of issues. I know that in Hong Kong, when we use this, Brian Yan is here, and they do blood pressure measurements in everyone. No one feels the pulse, but doing an ECG meant that we found patients with atrial fibrillation. It's very hard to do it another way. If you measure in the community and you get an automated device which shows you irregular, you need to be able to make a diagnosis on the spot, I think. But then to work out how you refer them is another issue. Neil, you agree, disagree?
I agree to an extent. The ordinary blood pressure machines that just say irregular, that didn't link with atrial fibrillation we detected. If you accept the IntelliSense type quality of detection. It wasn't helpful, so we ignored that, and so I think I've been impressed with the IntelliSense. I don't know, George, if you agree. It seems to me that's a good device and gets most of the way there, but it's still got to go on to somebody's from community screening. Then somebody's got to take that on, and that's our big problem. Interestingly, half the people who had a history of atrial fibrillation, whom we confirmed as having atrial fibrillation, half of them were being treated with those in CHAD-VAS 2+. So it's not happening. People are not being treated with a history and still with atrial fibrillation that we were able to confirm, which is very worrying. But that's another issue.
Yes, that's been so, and it's in different countries very different. So certainly in Hong Kong it's 25%, in China it was less than 10% in the community. And it's increasing in most high-income countries, but not up to near where we want it to be. But that's a completely other issue. The very last thing I think we have to do, because we are very pressed with time, Taimur, you said, what should we do in a combined screening study? With the different sort of, should we use the genetic polygenic risk score? Should we use one of Chris Gale's heart type of find AF algorithm? What would be the best way to enrich it?
Well, I guess the exact method doesn't matter that much. It's the increasing the yield, at least in my opinion. I'm not an AF screening pro, but it seems like in many of the studies the yield has been very low. So at least, well, that might not be feasible in everyday clinical practice, but at least if the polygenic risk scores are coming in the future, this might be one way to do it. If you could pre-screen them based on genetic risk, so there would be like I mentioned, yeah.
Okay. Well, look, I think we're over time, and we need to probably thank the speakers, Taimur and Neil, and also say this has been a really successful collaboration. And thank you very much, George, for being here with us. So I now would like to hand over to Renate Schnabel and Emma, I think. You're going to do the next section, which is to work out what do we do next? Quo vadis?
I don't know whether I need to ask this question because we have, in the past hours, we've seen so many open questions that would all need to be addressed. And so very quick, what you've seen and has been highlighted already is, can I have the slides on the screen, please? Because I see them here. So here we go. It was not in the back, so we saw them, but not the audience. So the recent publications, and I think they are all well cited, and it's important that we have all the experts here in the room and beyond to really provide input on such topics and really condense important information that is available already on different topics. And you all saw the email sent out again, requests for hot topics that we need to address. There are also some that have an ongoing discussion that I have put here. You will see, I just put them down, you will see some put in very similar topics, and I have combined them. But still, we've come up with 11 topics that might merit a position paper or a review paper. And important, I think, is when we consider this, is that for AF screen, we need to, it should not be merely theoretical, that is my opinion, but it should be really practice related, and how people can go on in terms of screening for atrial fibrillation or in the context with atrial fibrillation screening, atrial fibrillation treatment. So not too theoretical, and we always need someone to spearhead these efforts. Emma and Teemu led the last papers, and it's a huge amount of work. They are all exciting topics, I think, but there must be someone who wants to take on the lead and all the efforts with multiple co-authors. So having said this, should we go through the list of topics and then weigh whether this might be a good topic for the next paper and the next year of work that we will have after the conference here?
I think you might just ask Emma for her insights, Emma and John, for their insights into what it means to do one of these and work with 51 different co-authors.
Well,
when we submitted the last paper to the EHJ, it had, I think, 60 authors. And the EHJ said, we like the paper, we're going to accept it, and you can have 4 authors. You can imagine the question that arose. Well, I quickly worked out that Emma, of course, who'd done most of the work, had to be an author, and Ben had to be an author, so which other two? And of course I had to be an author. So which of the others would we select? Well, we decided that we would take the European Heart Journal on and said that everybody had done a lot of work and we would like them all to be accepted. And you see that the EHJ eventually took that position. But as a journal, they are asking all large multi-authored papers to cut down the authors considerably. And our argument that everybody did a lot of work was not quite true. And we have a saying in the UK at least, good cop and a bad cop. I have got to be the bad cop today and say that although we want everybody to consider which paper they would like to recommend and which paper they would like to join the authorship on, we cannot necessarily accept 60. And importantly, because some just want to add their name to the paper and not make any contribution, and in particular, not to reply to any damn email. So please can we have your conflicts of interest? Please can we have your ORCID number? Please can we have your agreement to publish the paper? That, I think, delayed the last paper, which fortuitously came out today, by, I would estimate, at least 2 or 3 months, something like that. Emma.
Yes.
So we would take the view that if you have something that you actively want to contribute and feel you want to contribute, we're delighted to have you. But if you don't respond to emails, we will just chuck you off the list. As simple as that. So that's just a warning from the bad cop.
Excellent job, bad cop. So
You can see lots of hairs that have fallen. I know what it was like the first time, and I'm sure, Taimur, you know what it was like when you did it. It was just the same. So it is important that everyone who wants to be on it makes the contribution and then actually says, I will actively be following this and make sure that I'm prompt with my feedback, etc. Otherwise it becomes impossibility. We need to make this look as though it's written by one person, which it isn't, and otherwise the editors don't like it. If there's repetition, needless repetition, they don't like it. And if you can cut it down, then it looks much better in the end. And you have something that you're really proud of in the end that is well cited. So I also sort of have the same plea from the heart. But we want to give everyone in the organisation, in the collaboration, a chance to do it. But we'll probably look a bit more closely about what you can contribute.
So perhaps we could invite some comment from the audience about ideas you may have that are different to these ideas, or would like to say a word in support of any of these ideas. Go ahead, Giuseppe. It's coming to you. I'm sorry.
Or you can come to the stage.
These are documents and not guidelines. But anyway, I think that in choosing a priority for one of them, we should consider what will be produced in the next years, this year and next year by the European Society of Cardiology. This year there will be a consensus document on mental diseases, so there is some overlap with psychiatric. Next year there will be an update on heart failure. So surely the approach to HF-PEF will be covered, and probably this document could be in competition. If I can make a comment, this group started on AF screening, so I think that this topic targeted AF screening, recognizing the multidimensional risk, which is both at 0.5 and 11, are perfectly in line with what we have addressed in this year, and there is a lot to do on this. So I think this should be the main sponsor potential objectives.
Yeah, indeed, the topic should really be related to atrial fibrillation screening, progression, and treatment. Right. So, yeah.
Please, yes.
Stavros?
Can't see you, but the microphone is coming your way.
Thank you. I would like to suggest a little bit different topic, but somehow related. I think we've heard a lot about AI. So I would like to suggest a topic where we examine the use, the optimal use of AI to enhance AF screening yield. The pitfalls, how to implement it in practice as well. So it's both implementation and
so you've really got number 5 and number 11 plus AI optimal use, which would be part of it together.
Yeah, right. AI has been on the topic list for several years now. To date, we always said there's not enough really evidence that we can provide. It's not a recommendation, it's not a guideline, but at least that we have some central statements by the experts and that are practically relevant, because then the papers are read. It's not theoretical constructs that we should discuss, but maybe AI will always play, in most of these topics, will play a role, and possibly we could start thinking about really having with a Cascade study and the others studies that have been published and are upcoming to really have an issue or a paper on AI and atrial fibrillation screening.
Johan?
Johan,
I would suggest maybe collateral arrhythmias. When we're using continuous ECG nowadays, other significant arrhythmias are more frequent findings than AF. And this also docks into the thoughts or limitations of the pathways as well.
I think there will be a presentation on this, or some of it, I'm told, in Amalfi. I'm not sure if that's correct. Person from Amalfi, at the back.
Limited. Some in the paper.
Some in the paper, but not in the presentation?
Correct.
Is the paper coming out, or?
We'll take a seat tomorrow morning, 11 o'clock.
Okay, we can't wait. Thank you.
Could I, it's Andrew Cohen here, could I just come back to the AI potential? One of the things about AI and the work that we've done is that most of them use a semi-structured analysis where you accept the regression-based risk factors and then you see what AI adds. And I think it'd be quite interesting to have an overview. It wouldn't be difficult, an overview of the papers published and look at the AI recognised risk factors and see if there's any similarity. because they throw up all sorts of things. They throw up in a time-related or time-varying analysis. They don't just throw up the baseline variables. They throw up the dynamic variables, and you get things like what we discussed today: changes in hypertension, changes in pulse pressure, which may actually be AF, or changes in heart failure presentations. And if there's consistencies, that might help us recognise new factors to predict AF.
Thank you.
Paulus?
No, you go ahead, please, Paulus.
Okay, thank you.
I'm just trying to get the microphone down here as well.
Oh, okay, sorry. So I think great discussion, great list of papers. I'm continuing on John's role of the bad cop. I think the elephant in the room for me is the question is, why do we screen? What is actually the consequence of AF detected by a blood pressure machine, an ECG, a PPG, etc.? Do we anticoagulate everyone? Probably not. Do we give everyone rhythm control? Probably not. And I think this group should address this. And my feeling is that something that is between number 5 and 6, what would the next potentially, I haven't seen Amalfi, so maybe that everything is different tomorrow at 11, but
we did try to address that
in
the last white paper. So we did try to address what do you do with recently detected AF in whatever way, whether it's screening or other. So it is more or less along the lines of what was done, but yours raises just some extra questions. So I don't know how much different it would be from what has just been published. But could we sort of... Yeah.
Sure, hi. I just wanted to add detection and management of AF in Indigenous peoples, that in a study that we've done in Australia, it's not published yet, we found a 15-year earlier onset for Indigenous people. Be interesting to look at the data internationally and how that would impact on screening age and, of course, management.
Thank you.
Ben, do you want to comment on this? Because you've also been working in this direction.
Well, Carly and I have worked on this in the past, so that's exactly right. I'm not sure if that should be the next white paper of this group, and mostly I'm told that it's too specialised, too small a group, and not relevant across. But I think it would be using the Indigenous researchers who have been working in this to try and do something that may be a more targeted review on that is something that would be quite possible. But I'm not sure that it would be the next white paper of the whole group. That's my own personal opinion, and I'm fairly biased towards Indigenous.
Thanks. 5 and 11 clearly stand out and are the same, and I'm very biased that that I think we should be doing something in that area, and I'm happy to contribute to that. The other obvious thing is 10, obesity and AF screening, and I'm not sure if anyone else ESC-wise is doing something like that.
Yeah,
but
there is a
clear-
guideline 2026 on obesity.
Okay, so either we beat them to it, which I think is very unlikely, or we put a line through it.
Yeah.
So, okay, it's my turn. Okay, so actually we talk about AF screening just now. Professor Chen has mentioned actually left agents chain, and just now Julia also mentioned PI3K. Actually, there are also a lot of data showing that, such as NT-proBNP, GDF15, and other biomarkers. So I think, can we summarize the current evidence in terms of the imaging and cardiac biomarker to increase the effectiveness of the AF screening? Is that an interesting topic?
Well, that could be 5 and 11, couldn't it? I mean, it could be a larger topic if you included the biomarkers, the genetic polygenic scores, the AI of the ECG, the AI of the medical records. How do we sort of target screening. So I think there could be a lot of different chapters with quite important comments, with contributions from different people, and then bringing it together in the end. It would not be an easy job to bring it together because they're somewhat disparate, but to me it seems the most meaty of all those that have been proposed so far.
Although I must say that always in the last papers we always had a part on biomarkers from imaging to natriuretic peptides, etc. So of course there is increasing evidence on that, and we could summarize it.
Yeah.
And
any other comments?
We've
got one. You, yes.
The second point, atrial fibrillation screening in patients post-stroke. Of course, we all intensified screening in this patient group, in the last 10 years or so. And I wonder, is there a lot of evidence that this did any good to the prognosis of the patient? We find more paroxysms of atrial fibrillation, but what's the outcome? Is the outcome improved? What's the evidence for that we do that? Because all the old data on the relationship between stroke and atrial fibrillation come from permanent AFib found on an ECG.
Yeah, no, I think there would be an opportunity for us to look at a sort of daughter of the post-stroke, but that may be a sort of a smaller publication, a follow-up.
And Luciano Sposato has volunteered to do this.
And also Teo Glotzer is taking part in a great debate with someone else to say we should screen or we shouldn't screen more after stroke. So there is still that's done, but it would be a follow-up and not a main sort of full. I suspect that's my view.
I think we've only got another few minutes before we've probably got to move on, but there are a few more questions, so can we at least hear the comment and question? We might not be able to give the responses if we want to hear your comment. Neil, go ahead.
Just to link, I don't know if anyone had the misfortune to read Tom Frieden's article in The Lancet about a Viewpoint article. He said, get rid of mass screening. It's a waste of money. It takes money away from what we really should be doing, that is treating people to know we've got, in a word. And we're talking, this links in with some of the other things, we don't have money. Most of the cases around the world, you saw Jeff's slide, most of the problems from atrial fibrillation, the deaths, are elsewhere in countries that got no chance. It's got to be done for the moment, realistically, opportunistically. So you've then got to go with opportunistic screening, and that's, I mean, I'm not trying to suggest that it should be number 6 and it should be in blood pressure screening, but I think it's in mass screening that's taking place now, and use opportunistic screening. General practitioners, they're not doing it in UK where they've got the money. So you've got to have mass opportunistic screening, and that at that time the yield is low, 2%. If you do it over 60, 65, you maybe get up to 3%. Meanwhile, Frieden said our blood pressure screening is a waste of time with a yield of 30%. Okay, so and just think about the monies involved with this. The stuff you're talking about, the sort of measures are just not realistic. Around the world, that is not going to happen, and you're not going to do an international impact.
Okay, there was one more comment. Oh, well, yeah.
Here. So among the things on the list, like 2 and 9 jump out as different to me because they're patient-driven rather than health system-driven or physician curiosity-driven. I think we've heard about 2 in post-stroke, but this provoked, triggered secondary AFib, 5-10 years ago, we were calling this reversible AFib, and it was forget about it. And then we've seen the guidelines now have jumped ahead, which have said, yeah, just anticoagulate it, which to me I think is also a little bit crazy. Right? And I think there is a real intermediate step for a patient who said, I have a problem, you have some tools, and they can go together. What is AFib in these people? They do probably merit rescreening. They can't be dismissed. And I do think that that's somewhere that's really patient-driven in a true problem that clinicians face, that you could give something useful.
Good comment. Thank you.
Thank you.
I would like to echo what Bill said, and also make the comment that number 8 is very clinically relevant, especially in the area of consumer screening, and it can be combined with 9, because some of those could be, the secondary AF could be more prevalent in the young or younger population.
No, secondary AF is more prevalent in the older population, and they have a terrible prognosis.
And I think you were talking about alcohol and stuff like that.
Yeah, I'm talking about not secondary, but provoked, like binge drinking and the younger.
So, okay, I have put down some additional ideas. Maybe we could ask people who really want to, you have outlined the good things and the bad things about being lead of such a paper. Maybe if people are interested to really take on the lead and work on this over the next half year together with 60 co-authors, then they can email Ben and me, I think, and we'll also reconvene and try in the steering committee to identify and combine topics and see what might make most sense, and probably also check with the ESC and the paper schedule of the ESC, not only the guidelines, in order to come up with reasonable topics.
Yeah. But we did try and throw a fairly big, broad net, and we asked our members a number of occasions to propose, and this is the distillation of that. So it's not just what we thought of just now.
Marius.
Yeah. Yes, if we have time.
Yes,
I'm a new member, so I thought I may take the opportunity to present myself. I'm Marius from Norway, and I've been doing my research mostly in the athletic population with atrial fibrillation. So I was happy to see that on the list.
Of
but
course, you emailed it to me. I put it up there.
I'm not sure, the next white paper should be on screening for AF in athletes, but instead I would propose maybe that a more comprehensive screening on the role of physical activity and exercise, both in the primary prevention and secondary prevention, not at least in AF patients, could be a good topic for, if not next year, for the future.
Yeah, also for prevalent atrial fibrillation, some information on the studies out there for exercising.
There are some already, and there are ongoing trials as well.
So one more comment, question, topic. Or speak out loud, then we can.
It's coming.
Yeah. It's coming.
Final.
Thank you. We have covered all 11 possible topics, so I think we have supported everyone. I will just follow the point that made Paulus, because I think that the point number 6 for me is particularly important for the AF management strategies, and considering as in the various population patients with asymptomatic AF. I think I agree with also with Giuseppe that the topic of the group is the screening, but in the clinical practice we are going to screen much more patients, we are going to find asymptomatic patients much more, and we should give some information on what we should manage this patient. I agree that we cannot treat for on the same way everybody with the rate control all patients with asymptomatic AF, but maybe to make a point on this could be important.
Okay, that's a good concluding remark, I think. And therefore we should go on to the next session. And I think Jeff and Emma, you will take over.
So we'll move into the space of AF burden after the consensus document recently published. And I'd like to invite Wolfram Derner, who was the first author of that paper, and we'll discuss if there will be a single burden cutoff. So welcome. Hi.
Also, my great thanks for inviting me to this meeting. I wasn't able to attend for the last 2 years because there was ESC stuff with conflicting time, but I'm really happy to be here and to discuss this topic of AF burden with you. this is very much in the focus of the discussion in clinical work, in research, development, epidemiological data. 70 plus times mentioned in the guidelines, AF burden. But when it comes to how actually we define AF burden, then it's getting immediately complicated. Basically, we do not have a single definition of AF burden, and what you see here is just a summary of a couple of dozen different definitions that have been used, bringing guidelines up to the level to say, however you use AF burden, make the definition in your paper and then go on with actually showing your data. And of course, by this way, this prevents any kind of comparability, validation of any kind of cutoffs, whether it's a single cutoff or multiple cutoffs, it doesn't really matter. We need a unified definition, actually, that we talk the same language in terms of AF burden. And this was the basis for this paper that has been published just earlier this year, actually to put this basis in the discussion as the stepstone for the ongoing research, to define in a uniform way how AF burden should or could be assessed. The paper also addresses other topics in this context, how actually as the technical implications that such a uniform definition could have, and what is the advantage and the tricky aspects with implementation in clinical entities, in clinical diagnosis, and also what would it make an impact for this trial design and for device development when we have a single definition. And the the uniform definition that has been proposed in this paper is briefly showing here again. It's defined as the proportion of time in AF during a specified continuous or near continuous monitoring duration, which should also be reported. So this is not brand new, nothing out of a black box. But what is new in this definition is actually two minor aspects, and that is first, we say to make a comparable duration of the measurement continuous, or at least as near as possible to continuous assessment. And what we also say, and this is vitally important, to ensure comparability between studies, that is, however the length of your monitoring period is, you need to report that length. Without that, any number you provide in your data is not comparable with any data, with any other clinical research results. Another aspect that has been also addressed here is the longest period of atrial fibrillation should also be addressed, also be reported. However, there was a lengthy discussion in this consortium that the longest period is not actually part or should not be seen as some kind of AF burden. It's a separate assessment. And this consensus document goes on and also addresses the question, that is the topic here now. It says, this unified definition applies independently of an underlying comorbidity or outcome to be addressed. However, for those targeted clinical outcomes in specific populations, there is the need to define disease-specific actionable thresholds. So the answer is already given in this paper. We cannot rely on one single cutoff, one single threshold for a variety of clinical conditions and diseases. And it's easy to understand if we just go one step back and look at intermittent atrial fibrillation. It's basically the summary measurement of a number of pathophysiological principles that are involved in this paroxysmal AF burden. Thromboembolism is only one factor that pathophysiologically plays a role here. There is myocardial remodeling, there's vascular remodeling from pulse wave dynamics, there is hemodynamic aspects of organ perfusion that may be altered by paroxysmal AF, and of course, the sensation aspect of atrial fibrillation, all those play a role to a different degree when it comes to different outcomes, that only the most important ones are listed on the right side. So altogether, these needs to be taken into account to address the clinical significance of AF burden, and that makes it understandable that different outcomes are differently affected by the temporal pattern of AF, and therefore these different outcomes require different actionable thresholds, not one single but different ones. To illustrate this a little bit more in detail, I'm showing just a very few slides. These are not about the data that is shown here. I think a critical view on the data is given by Paulus in the next presentation. But what I would like to make the point is here, these are outcomes, different outcomes with regard to paroxysmal atrial fibrillation. And you can see from the y-axis of these just 3 examples, mortality, hospitalization, and stroke, that there are different percentages in the y-axis, and also the slope of this interaction is very different. So I think it's pretty clear, or it's pretty well understood, that we have a dose-dependent relationship between AF burden and different outcomes, but the degree of this dose dependency of this relationship is very different. And that, again, is an argument in favor of selecting different actionable thresholds. There's another point that needs to be addressed in terms of deciding on clinically applicable thresholds. That is not only that we have actually that we have a unified definition for AF burden, but we also need to address whether we want to look at this from the epidemiological perspective. So actually looking for thresholds according to the risk of an outcome, or whether we want to look at this from the clinical effectiveness of treatment perspective, looking at thresholds according to treatment effects of certain outcomes. These two possibilities actually are options that need to be discussed in terms of coming forward with actionable thresholds. And again, just to illustrate to you a little bit the complexity or difficulty of the existing data. This is again only for illustration purpose. This is the AF burden after a treatment for ablation, and you see that a threshold has been identified in this trial from the Castle AF of 50% AF burden. So if you reach an AF burden below 50%, you had a significant improvement in these outcomes. I just want to make the point of the 50% threshold. Another clinical investigation looked at other clinical outcomes with a different way of assessing AF burden. And what you see here is actually a threshold. No, sorry. That is... Can I go back? Yeah. Is the clinical threshold of 0.1% to have a significant impact or a significant message for a relevant threshold. So you may easily understand that these two aspects, an AF burden of 50% higher or lower, or an AF burden of 0.1%, these are completely different ballparks. And we need to find ways actually to adjust our assessments according to those endpoints. And it may not be possible to put these two into just one uniform threshold. So altogether, what I would like to sum up is we did one step by proposing a uniform definition for AF burden. This is the, as I said, the stepstone to allow comparability of clinical data and to allow validation of such cutoffs. It will hugely benefit the acceptance in the clinical work to have such a uniform definition, and it will hopefully also promote clinical trial design for joint endpoints and also for device development. But it's just the first step to go, and further to do is actually on our list to identify those actionable thresholds based on disease-dependent characteristics, based on outcome-dependent characteristics, and finally also to clarify whether we want to go for epidemiological categories or for treatment efficacy. So altogether, the answer to that question I had at the beginning is yes, we have one definition, but we need the outcome-dependent clinical applicable thresholds. Thank you.
Thanks, Wolfram. And maybe do we have time for a question here now, or should we wait? We'll wait until after Paulus presents the data to go with this previous talk. So Paulus, welcome.
Sure. Brilliant. Excellent. I will tell you how I got interested in AF burden, and I think it actually is quite pertinent to screening and to many of the things that we've heard today. These are my disclosures. So this is, I think, one of the first ECGs of atrial fibrillation recorded by Willem Einthoven in 1906. And this is what we're faced with today, and this is just one picture, and there are many. And of course, one of the effects that we see in clinical practice, in screening trials everywhere, is that we get more diagnosis of AF, more patients with AF, and on average they have a lower AF burden because those with infrequent AF are picked up with modern devices. And on the left is actually the impact study that Greg Libb led, published in 2018, that was already testing intermittent anticoagulation in patients with device-detected atrial fibrillation. And that had a neutral outcome back then. And then Loop had a neutral outcome, and I would like to quote the main investigator, that they wrote, this is from the Lancet paper, "These findings might imply that not all atrial fibrillation is worth screening for, and not all screen-detected atrial fibrillation merits anticoagulation." And now the other bit of evidence that I was involved in is, of course, the EAST-AFNet4 trial. And what I want to highlight here, so early rhythm control for all in the first year after AF diagnosis, done mainly with antiarrhythmic drugs, reduced cardiovascular events compared to usual care over a 5-year time horizon. There were a third less strokes in patients randomized to usual care compared to randomized to early rhythm control compared to usual care. It's actually the same relative risk reduction that was seen in Athena. There's a stroke sub-analysis of Athena, and dronedarone was associated with a 30% lower stroke rate. So there is something about rhythm control preventing strokes, potentially. This is the Athena part. And at least in EAST-AFNet4, that effect is mediated by sinus rhythm at 12 months. Then the other bit, and that of course is, well, it's now almost 2 years that we share these discussions. I think, yeah, it was at ESC 2023 that we presented NOAA-AFNet6. At the other end of the spectrum, you have patients with device-detected AF who typically have a very low AF burden. We haven't published our AF burden data in NOAA yet, and I don't think you have, Jeff, but they are available in Loop, and it's 0.13% is the average AF duration, AF burden in Loop. So NOAA was stopped prematurely because of expected safety events and a trend towards futility. Artesia was continued a bit longer and found a small stroke-preventing effect of anticoagulation in patients with device-detected atrial fibrillation. Now, the most remarkable thing in both trials to me was the absolute stroke rate was identical and was very low, 1.1% per year, with aspirin or with placebo or aspirin. In a population that was almost 80 years old and had a Charts-Vask score of 4, so a third being women, probably a Charts-Vask score of 3.5. And the trials are consistent. That's the trial-level meta-analysis published by Will, who is probably in the audience somewhere as well. And it's not the duration of AF. So this is not animated. There is an AF burden sub-analysis from Artesia. That's the lower of these two publications. It basically states AF burden doesn't affect outcomes in Artesia. And when we look at the patients who had a longest episode, longer than 24 hours, they weren't even enrolled in Artesia, there is no effect on stroke rate either. And I now think that this is because we are looking at the very low end of the AF burden spectrum. I think you've all seen this. This is the effect of anticoagulation in patients without vascular disease in both trials. Renate presented this last year at the ESC, and what you basically see is that you can't discern even the curves with and without anticoagulation. So in patients with device-detected atrial fibrillation without vascular disease, there is no effect of anticoagulation, even though they have a little bit of atrial fibrillation. And there is a signal in those with vascular disease. And I think we could debate for hours whether that's due to the little bit of atrial fibrillation interacting with vascular disease or whether it's something else. So, and this is how we put this in a review article last year. Basically, when you go from chronic to paroxysmal AF, you have a 10-fold average reduction in AF burden from 100% to 11%. And then when you go to rhythm-controlled AF, it's probably closer to 1%, so it's another 10-fold reduction. Then device-detected AF, at least in loop, it's another 10-fold reduction. And the stroke rate follows, but at the lower end, the effect of stroke may actually be quite small. So it may well be that an AF burden of 1% is acceptable when you talk about stroke risk. And then we will actually have a presentation on a win ratio of the NOAA-AF trial. I just wanted to mention this here because it's the last day of the Congress, so stay until Monday afternoon, rebook your flight, and go and listen to Nina Becher-Boltholm is actually chairing that session, I learned today. So we can't wait. Now, you've already heard this, and this is actually from the Castle HDX trial, and it's exactly the same. AF ablation in patients with advanced heart failure reduces AF burden from a median of 50% to a median of 20%. And that reduction is associated with better survival, at least in these two small trials, and less heart failure hospitalization. So it may actually not be the absolute burden, but it may be the amount of AF burden reduction that that is relevant for AF burden when you think about clinical practice. And Uli Schotten will give another presentation looking at the AF burden estimated not according to your consensus paper, because this is on weekly short-term ECG recordings. It's certainly not near continuous, but he looked at how the AF burden on therapy in the early rhythm control patients in East AFNet4 affects outcomes. And unfortunately, it's the same time as Nina's presentation, so you'll have to choose.
I guess my mic is live.
I made Jeff laugh. This is a good day. So, in summary, I think AF burden is potentially at the bottom of quite a bit of the conundrums that we've seen in the AF screening trials. And I do think that quantification of AF burden using a simple definition will help a lot, but there are more answers than questions. And that is, of course, exciting when you are a scientist, but a bit disappointing as a clinician. Thank you.
Okay, I'm kind of scared to speak now, but it seems to be gained up properly. So, open for questions.
And I think, John, you had some...
Do you want me to do my little piece
yes.
first?
Yeah, sure.
Yes.
Yes, please.
I've been asked just to say a few words about AF burden and questions related to AF burdens. And I think you mistakenly said a moment ago that there were more answers and less questions.
I've
just
meant the opposite.
I think so, yeah. I wanted to explain that there were a lot of questions. So could I have my slides, please? So this is the distribution of AF burden. And I think we need to appreciate that it's bimodal. You can see on the left, of course, the low burden. It's mostly so-called paroxysmal atrial fibrillation. On the right, it's mostly persistent or permanent atrial fibrillation. But the authors of this Orbit AF2 paper were keen to point out that some of the permanent AF had considerable amounts of sinus rhythm, and some of the so-called low-burden patients, some of the paroxysmal patients rather, were a very high burden. So the clinical classification doesn't work very well according to these authors, and I think we've all appreciated that for some time. But the main issue is for us as AF Screen is what is the relevance of AF burden with regard to screening. So the next slide will show you that there are many questions about burden that we could ask, and they're all very relevant, but very few of them relate absolutely directly to screening. So, for example, we don't need to worry about whether we can use burden for clinical trials or not, but perhaps some of these questions have some relevance. What's the definition? How can it be measured? How does AF burden relate to adverse outcomes? Are there thresholds for these outcomes? Are they consistent? Do they change with underlying substrate and so on and so forth? But perhaps the most important issue is what are the implications of AF burden for screening, and is burden relevant to what we discuss? So I think that these are the two main questions that we as AF screeners need to consider. Does a consideration of AF burden lead us to any conclusions about how AF screening should be performed, and perhaps how it should be implemented, the results should be implemented? And should AF screening involve an assessment of AF burden or lead to an assessment of AF burden? So that's what I would like to leave you with as the most important questions for an AF screen community, because otherwise I think we'll get totally lost in other issues related to AF burden. That's all.
I'd just like to make one comment, that half of the authors in the burden consensus document were members of AF Screen, and a couple have come members since that document. So it is of great relevance to us as a community of screeners. So I like the two questions you've posed. Thank you very much, John.
Yeah.
Hi, Singer again, Boston. Couple of points. In GUARD AF, the correlation between length of longest episode and percent time in AF was a Spearman correlation, was 0.94. Just a point of interest, which is to say that the two, they convey the same information. Actually, the number of episodes over a given period of time added some new information. Whether that's related to stroke risk, I don't know. The second, you made the assertion that there was no relationship between AF burden and stroke risk. No, I mean, Jeff has made that in a paper, and I thought you had reiterated that. That's AF burden at baseline. That's prior. So that may or may not be relevant to this issue, right? And the other thing I'd point out, just a little tidbit, is that if you look at the watches trials, you know, the Apple trial and the Fitbit trial, that the burden, the way they use it with irregular heart rate episodes really are 30 minutes or longer, and so that actually the burden involved when you're using a watch using that approach means that your burden is much higher. It's just a point of interest. It's not the same thing as it's not 30 seconds.
Not an AF burden modeler, but there are actually quite good data to suggest that the longest episode of atrial fibrillation is a very good correlate for AF burden when you have long monitor time. So I don't know how long that was in GUARD AF, but 14 days. Okay, well, but that is the AF burden over the same 14 days. Or yeah, okay. But that may still identify people with a similar AF burden who, when you monitor for a year or so, have a different AF burden. I think the comment on baseline AF burden is well taken. My impression is that there is a correlation, and it's probably an exponential one. So every tenfold reduction in AF burden brings you a 1% or 1.5% absolute less stroke risk without anticoagulation, and that it tapers out at the low ends. Now, I think the challenges with some of the studies that try to correlate actual AF with a stroke event is that it's not simultaneous. The factors that lead to a stroke in AF probably take days, weeks, or months to develop. And therefore, there's a famous, I think, ASSERT sub-study that shows that some people had a stroke and then AF only afterwards, or there was no good timely correlation. I think we'll both look at this in NOAA and Artesia, and it will be really interesting to see whether it's different on anticoagulation or without anticoagulation. But I do think a big challenge there is the factor of time, because you get very imprecise measurements when you look at, oh, this patient had an episode on Wednesday and a stroke on Friday, or the other way around.
A quick comment. Danny Singer's paper really showed that temporal relationship was present, and it was strongly reduced by anticoagulants. I think that's probably the last word on it, because you have the most strokes.
Taya?
I wanted to make two comments. One, what you showed Jason Andrade's work about ooh, wow, I got very loud. More than 0.1%. There was also a threshold of 1 hour. More than 1 hour duration predicted heart failure hospitalizations and emergency room visits and things like that. John's two questions, I mean, yes and yes. we have to look at burden. It's so important, and we can't just, look at a little bit. We have to have a measure of what's actionable. And in terms of the stroke risk, I think, is AF a marker or is it the cause? Right? Temporal relationship. I mean, I think it's both.
Yes.
I mean, and to jump in on a few additional things, I like what was brought up. I think the document that Wolfgang and others put forward is good, because you do have to measure leaf. You can't throw it out, because it may mark different things we don't know, so it's good to put it in as it was in that document. The other point is about the regressors, right? And this is your big issue. We did see, when you go from some burden to zero burden, in both studies, that seemed to be associated with better outcomes. And so, again, this idea that burden moves in large steps, 6 to 7% versus 9 to 12% probably isn't important, but 100 to 10 and 10 to 1 and 1 to 0.1 and then to 0 probably matters. Giuseppe.
Oh, we can go.
Go ahead.
Yeah.
And one there.
I have a question about the term device-detected AF. Which device? Are oscillometric devices the same? My impression is that the blood pressure monitors, to avoid false positive, require more information to report AF. They have the rule of 2 of 3, and they take at least 3 assessments, and if 2 of them suggest AF, they report AF. So they may reflect more burden of AF than PPG devices. So the question is,
what device?
Which device? Is it one term for device detected? Which device detected?
Paulus, which device?
I think the term was coined to reconcile subclinical AF and atrial high rate episodes. So it's implanted devices, pacemakers, defibrillators, CRTs, loop recorders, or to say it in the terminology of the consensus papers, devices with near continuous monitoring. So neither the typical used PPG device nor the blood pressure monitor, and certainly not the Alive Core or the daily telemetric ECG that we used in ECAFNet4.
I think the blood pressure monitors are different.
Oh yeah, they are probably still different, but they will. So for the term device detected AF, neither of them applies. At least that's sort of the current use of the word. And I see a few nodding people around.
One consideration: the outcome of reference is stroke, and the American guidelines put 1% per year of stroke as the threshold at which anticoagulants should be considered. So with this trials on subclinical AF, we are not far, because it's 1.1%. As an important issue to consider is that these strokes are not frequent, but 40% in Artesia were ranking 3 to 6, so disabling or fatal. So the balance between bleeding and stroke should put in the right perspective the risk of stroke in terms of annual risk and consequences. This is something we usually do not consider too much. So one point is the percentage of occurrence. The second is the severity. The European guidelines did not put this threshold. Danny, I don't know if you want to comment. You suggest another one, which was a bit higher at the time of VKA. But this, for those who are not so expert as probably we are, should be the reference. Would you like to comment?
On what specifically?
No, what is the threshold of a risk of stroke without anticoagulants at which we should consider anticoagulants?
I'm not the guru on this. We published a paper, a decision analysis paper that is influential and often cited in Ekman et al. And it's with DOACs, it's closer to 1%. With warfarin, it's closer to 2%.
Human? Did you want to say
a very
something
quick comment and to ask, Wolfram, you were the chair of the stroke working group for a period. I have worked with a lot of stroke neurologists. We have one in the audience, I think, still. For them, any AF is treatable after a stroke. Why shouldn't burden be important post-stroke?
I think burden should be terribly important. Only current clinical practice is a yes or no approach. You know, you ever stumble across an ECG where there's an AF, hey, you get them on DOAC. And I think this is too short of thinking and too less sort of challenge. This is too simple, this thinking. But this adds, or this leads to the question that John asked, whether those two things, atrial fibrillation, yes or no, and AF burden should be answered sequentially or at the same moment. I think because we are already good in deciding about AF yes or no, we should take this as a first step. But as soon as we identify some kind of AF, then the assessment for AF burden should be a second step. And I think by this, we put far more sophistication in this concept and also for treatment approaches.
Yeah, I agree with that, Wolfram, a lot, and it may be incorporated into the rest of our clinical scores, because it's quite clear from both of our studies that there's large swaths of the pacemaker and ICD world where finding and treating makes little or no difference, right? They're very low-risk individuals, and again, does that get merged, a burden score, along with clinical risk factors? Is there a different threshold in a stroke patient compared to a person with few or no risk factors, or a moderate level of risk factor?
Exactly.
And I don't know, Professor Singer, if you did this analysis in the GUARD AF, but you could, Linda and I did some modeling in her 14-day halters, and you can clearly see that if you don't have any AF quite early, you're not going to have a great burden of AF during the monitoring period. So it's quite interesting to see also how much do we need to monitor in order to catch a relevant AF burden. So I just think that's also an interesting point, but I'll let you in. Oh, sorry.
I was just going to make, I'm not editorializing on
Can we turn on that
anticoagulation, but the background rate of stroke in people over 65 is like 0.5%. So when we talk about 1%, it's still twofold higher than the average stroke risk in people over 65.
Should we do a final comment by Bill? Yeah.
So I think burden's attractive, and I remain very interested in it. But I think we need to remember that we're approaching this from the lens of AF screeners. A lot of our evidence comes from therapeutic AFib, where you go from persistent AFib or paroxysmal AFib that's high enough to be relevant, and then you knock it down, and when you show like a logarithmic drop or something, it's therapeutic. On the screening side, we have to remember that anytime we're screening, 95% of our patients don't have AF, and I think we need to be very careful in the screening world, because as much as burden is a continuous measure, and that's incredibly attractive, the zeros are very, very penalizing when you try to use it statistically, that they actually handicap you the other way. So I have some reservations about burden in the screening world, where I think in the therapeutic AFib world, I think it actually has the most bang.
So Paulus,
Good
maybe
point.
you can have the last word while
Yeah.
we get Bill down here ready for the next talk.
Wolfgang actually said, I think, an important thing. AF burden is probably something that is part of the assessment of patients with atrial fibrillation. I think that's mainly what you said. But I do think it has, one of the reasons why I started thinking about AF burden was the outcome of stroke stop, end of loop, and then of stroke stop 2. According to all the models that we have, when you do 14 1-minute ECGs over 14 days, and you detect AF there, those are people who have an AF burden that is very likely to be above 1%, probably closer to, but the trials came out the way they came out. So I do think it is relevant, and I do think having an enrichment strategy that follows detection of that first ECG is, in my view, relevant, and that's where maybe AF burden is helpful. I don't know.
Yeah.
Emma,
Yeah.
you probably have
No,
a
I think that's interesting.
So let me throw down a question while we're getting set up. Are we now in a phase where we can say, let's randomize patients who are found during screening studies to anticoagulate or not? They have risk factors, they have screen-detected AFib. Can we go back there? Because this has been verboten for every discussion we've had on the topic before, but is this, or do we even need to?
I think we need to wait for SAFER, to be honest.
Yes. Well, SAFER will be the
Appropriately.
biggest by far. And when we do things, and we'll hear a bit about it today from Jonathan.
I wanted to add just one sentence to what Paulus just said about AF burden and stroke. And I would like to put forward to not limit the whole AF burden concept to stroke assessment.
Yep.
In stroke, we have this discussion about the longest period, the longest detected period, or AF burden. We have no such discussion in heart failure, in cognitive decline, in renal failure, in symptomatic state, maybe in symptomatic status. But there are so many more outcomes where the longest episode has far less impact and relevance, and therefore this is also one of the beauties of this AF burden concept. So this should be thought of bigger than just stroke.
Yes.
All right.
Thank you.
Thanks, Wolfram, for the last
Thanks,
word.
Wolfram. Good word.
So we do have to move on to the last session. We
Great
are
discussion. Thank
happily discussing things,
Great.
but on behalf of Ben, the co-chair for this session, we're going to get into the
Great session.
We're going to get into the randomized trial data now. So welcome Bill McIntyre to come down and talk about the individual patient meta-analysis. Give an update.
Been sitting up there far too long.
Okay, I've been waiting to play with this thing all day. It's kind of cool. Perfect. So really, I speak on behalf of everybody who's doing work, who's leading trials, and who has the bigger vision together to make sure that the trials that we do can be greater than the sum of our parts. So remind you the power of individual participant data meta-analysis. You can do study level meta-analysis, and these things are churned out week over week. But what's really important is you might be combining a study where everybody has a CHADS-VAS score of 4, or you're doing it in Finland, or you're using a patch, or you're using BNP. And when you try to put all those studies together, you get ecological bias and some of these drill down effects that we really, really want to know about, the influence of factors on our screening. They're distorted. And that's why individual participant data meta-analysis is ultimately what we're after, because we want to know more than should we screen. We want to know where we should screen, in whom, and how hard we should look. So this table just gives a little bit of a summary of the data that's sort of out there. And Søren Didriksen is housing a lot of this in Copenhagen with Jesper and his team. And you can see the blue ones are primary studies with published stroke data. The green are the post-stroke ones. There's some other trials that have AFib only data. And of course, tomorrow, I didn't have time to edit to say at 11 a.m., the Amalfi will be added into the sum of our total knowledge. So I thank the Amalfi team. This is a word of sort of their overview and what they're doing. So it's patients who are high risk, right? They're randomized to screening or none. They've got 5,000 participants and some cool outcomes that are going to add into our things. If you need to add that to your program, that will be there, and our sum total knowledge tomorrow is ultimately going to grow by another increment. On Monday, the sum total knowledge is actually going to grow a little bit more, and the first fruits of the individual participant data meta-analysis tree will be harvested. So Lucas Jing, who's done a lot of tremendous work, has done some really cool stat stuff, cleaned a lot of data. He's going to be presenting and asking questions about how does the population characteristics and the screening methods influence things. And again, this is all done with individual participant data, right? So everything's adjusted for each other. So you want to ask questions like, if they have heart failure, what's my yield, right? If I do it with a 14-day or a handheld, what's my yield for finding atrial fibrillation? He's going to have that to share with everybody. And since you've already rebooked your flights to hear the other presentations that Paulus has mentioned, that's good. This is a little bit on the work in progress. I don't know if Paul Heidenreich's still here, but Valiant AFib will start enrolling next year. There's another 25,000 patients that are going to be in the ethos and contributing outcome data. Axel Bauer is going to talk a little bit about Austrian Digital Heart. They're enrolling next year. There's 100,000 patients in that. Jonathan Mann's going to talk about SAFER. There's another 100,000 patients. There's so much yet to come. This is a snapshot of where we are right now, if you like to do it as it rolls in, time-updated study meta-analysis. You get the idea with each of these 6 studies here with randomized trials of atrial fibrillation screening, so REHEARSE, SCREEN-AF, LOOP, Stroke Stop 1 and 2, and GUARD-AF. The way the overall diamond goes is it tips in the favor of a reduction in stroke with screening, but obviously there's more yet to come. Obviously, that's a very heterogeneous group. If you're into trial sequential meta-analysis, it's kind of a cool thing. It's literally the same as doing stopping rules in a single clinical trial. And this is the way the curves and the saturation, the statistics are coming now. So there's about 75,000 patients that have been in randomized trials right now. You can see that red thing dipping in is kind of the stopping boundary at which you'd be oversaturated. The blue curve is sort of coming close to it. It makes a person very, very optimistic that this really, really does work. And I think it's important to know, within 24 hours, there's going to be another 5,000 patients in this. And then within the next couple of years, there's going to be over 300,000 in our future state. So we are coming very, very close to a really cool place for pooled overall knowledge. So I conclude to say that randomized trials really are the best way to move the needle. That's how we're going to get the U.S. Preventative Service Task Force to change their mind on what they say. There's 75,000 patients out there, going to be 80,000 soon, but the ongoing efforts, right, the things that are cooking right now are getting us to triple that. And kudos to the people who contribute that so that for the common knowledge, we can really, really figure out if we should screen, for whom, and how to do it. Thanks.
Thanks. Thank you. Great. Thanks very much. Right. Well, we have the next speaker is Jonathan Mann, who is the CI of the SAFER study. I must say I'm very pleased to be the only international arm, smaller than your arm. But yes, you'll tell us an update on where SAFER is. Thank you.
So I do have some slides.
You do.
How do it? Yeah.
Someone who's better than me at operating that on.
That's not
you.
Screen,
not.
No.
Can we have Jonathan Mann?
SAFER on the front.
Keep going. Technically, we look like one block, right? No. I have a third of a slide on your study.
It might have been. I mean, it's rolled in together on the program, but and we have your presentation because we received it.
Yeah.
Yeah, up to you, Jonathan. If you want to ad lib,
Yeah, well,
maybe
do you want to do one of the other ones? And what
Yeah.
I'll do, I'll just put it up on my screen, so it's because I can then get the numbers right.
So we'll. All right, Ben, so we'll move on to the next presentation here, which is, in fact,
North Green.
North Green.
I scream for North Green. Let's go. And Sigrun, I think we're very pleased to have you with us today.
Yes. Thank you very much, and thank you for the invitation to give a brief presentation of our Norwegian atrial fibrillation self-screening trial. And then how does this work?
You press the forward button, and you can point at it with the front.
Okay, thank you. The Norwegian study is a randomized clinical trial performed as a nationwide study in Norway. The aim of the study is to assess whether continuous screening for AF with a patch ECG in individuals 65 years or more with at least one additional risk factor for stroke and initiation of guideline-recommended therapy in patients with detected AF will reduce the occurrence of stroke in the screen group compared to the control group. The number of participants has been estimated to be 50,000, and these patients are randomized 1-to-1 to screening of standard of care. The primary outcome of the study is, as already mentioned, stroke, and the follow-up will be through linkage with national registries after 3 and 5 years. We published the design in Europace last year, so if you are interested, you can read more about the details there. I will just highlight a couple of things, and that is that the screening is with a patch ECG called ECG 24/7 Smart Heart Sensor, consisting of a disposable ECG electrode patch, a reusable sensor, a smartphone application, and a medical back-end cloud service. And the participants are recommended to use this, to wear this device for at least 3 days, but it can be used up to 14 days. The control group received just standard of care. Another thing I will highlight is that we use a fully digital approach in this study. Inhabitants aged 65 years or more from all Norway, they are randomly identified from the Norwegian Population Register. A digital invitation letter are sent with access to a digital inclusion-exclusion test, which they have to go through themselves. And if they fulfill all the inclusion criteria and have no exclusion criteria, they also have to sign the informed consent digitally through the bank ID. Then they are automatically randomized either to intervention or control. Then the ECG 24/7 Smart Heart Sensor is sent by post to those randomized to screening for screening at home. And we have a user guide supplied from the manufacturer and also a very useful help desk for phone assistance, not 24/7, but at least every day. And we started enrollment in the study in September 2023, and enrollment was completed in June this year. And in order to include 50,000 participants, we had to select more than 700,000 inhabitants from Norway. 150,000 of them, they were not digitally active, so they had no digital address, so we could not send any letters to them. But we sent them letters to 550 participants above 65 years or more digitally. And many of them did not respond, but 140,000 they performed the pre-screening that they had to do by themselves, and half of them were found to be eligible, but not all of them wanted to participate, so we ended up with 50,000 participants that then were randomized to screening or not. And if we look into more details about the reasons for exclusion, we did not want to have people that already had atrial fibrillation, so 10% were excluded due to known atrial fibrillation, more than 4,000 because use of OAC of other reasons, but the most frequent reason for exclusion was that they did not have another risk criteria according to SHADS-VA. Here you can see the baseline characteristics of the 50,000 participants that had been included. The mean age was 74 years, the median age 75. About half of the patients were women. The most frequent additional risk criteria was hypertension, which was present in 2/3 of the patients. That is what we have for our results by now, because we have just finished inclusion. So just to sum up, the Norscreen trial demonstrates the feasibility of a fully digital approach for AF screening, enabling efficient large-scale recruitment of study participants with little resources. We only have 2 million euros for this study. And we have included then more than 50,000 individuals during a period of 22 months. While enrollment is complete, ECG screening is still ongoing. It's quite time-consuming logistics. Thus, we still do not know the exact detection rate of atrial fibrillation. And we have to wait for some years to have the results of the primary endpoint. Follow-up with respect to outcomes will be through linkage to national registries first time in 2027. Thank you for your attention. Okay.
We found Jonathan Mann's presentation. I feel for you with the logistics of going from hundreds of thousands down to 50,000. Really complex study, wonderful thing that you're doing. Jonathan, from SAFER this time. We think we've got it?
Yeah.
Yes.
Yeah, great. Okay, thanks. So I realize it's late in the day. I'm going to tell you three things. One is where we are in the trial. The design is written, is up there, so you can, if you don't know it, you can look at that. I'm not going to tell you the design. I'm going to tell you I have one slide about implementation issues. So parallel to the funding for the trial, whether screening works or not, we were asked to work out how to do screening if it was to be done, and so we've been publishing on this in dribs and drabs over the years, and there's one more publication this year that I'll talk about very, very briefly, and then the timetable going forward. So where are we now? So basically screening, recruitment's completed, screening is completed, and so we're just in our electronic follow-up phase. I think the sort of interim process measures that are interesting, that from essentially single letters, we got nearly 28% taking part of the population taking part in this trial, which is actually very high for a sort of cold call consent. So the North Stream had very high once, but not many people responded to the first thing. So yeah, that was very good. The uptake of screening was 80%. We had an AF pickup rate of 3.5%. So that's fascinating to discuss and compare with Chris Gale. I think you ended up with 4.5% in the end. So so that's an interesting sort of discussion. And there's been a lot of discussion during the day about the other things you pick up, and you can see how the proportions that we picked up down there. So that's enough about the trial. So along with other people who've talked about this already, we had the good fortune or misfortune to aim to start our trial in 2020. And we'd envisaged, as I think everyone envisaged at the time, that AF screening would be done by sort of clinical people, clinicians, basically. Apart from sort of wearables, but essentially it would be a clinical thing. And clearly during 2020, all contact with clinicians for members of the public was kind of discouraged, really. So we pivoted and looked at whether we could send out the devices remotely. And we wondered whether, well, do the practices need to do it, or can we do it ourselves? So we did this little study with 3 practices. All the devices were sent out. In one practice, it was sent out by the practice, and training was provided by the practice nurse for everyone. In the other two practices, it was just sent out by ourselves, and we varied randomly the amount of training that we offered in terms of how to use the device. The bottom line is, and our outcome for this was whether there was adequate quality ECGs, at least 56, using the automated software for detecting poor quality ECGs. And the bottom line was that it made no difference. We didn't need to offer any training. It wasn't any better if the practice nurses did it. So a lesson to the power of the members of the public to be able to follow instructions without any formal training.
And the power of COVID.
And the power of COVID too. So then finally, our next steps. So next year we're hoping to publish the results of our pilot trial, which had 14,000 people in. It won't be the outcomes, but I think the outcome that we will be reporting is quality of life comparison between the intervention and control, which I think is of some interest. We'll be doing further process analyses that are relevant to what's been discussed today, not least how people with AF were managed, how people with indeterminate AF or other significant arrhythmias were managed. And we've got a lot of data about satisfaction with screening from a simple questionnaire that was sent out to participants for the first couple of years. We plan an interim analysis of outcomes, not by arm, but by the whole study population to see if we need to extend our length of follow-up just on the basis of whether the event rates are what we expect. And we've put in we put in some funding application to NIHR for a sub-study to evaluate a training package to improve the reading of single-lead ECGs. One of the things that wasn't covered today at all is that single-lead ECGs are very difficult to read. There's not agreement between experts, and we gloss it over. So anyway, we're trying to put that square on the agenda, and it is an issue in screening programs.
Who reads single-lead ECGs? Keep up your hand if you find them not so easy sometimes. Thank you.
And also, if we get funding, we'd like to get in touch with you to get directly involved in our study. But I'm not going to describe that study anyway. But if you do read single lead ECGs and you would be interested in getting involved, please send me an email. Thank you. Sorry for that shameless plug. Right, so we will complete our follow-up in 2027 if the outcome rate's roughly what we expect, so we hope to report in 2028. Thank you very much.
The total N, including the ones from the pilot, what's the total N randomized?
104-ish, 104,000.
104,000-ish. Thank you.
Ish. Well, I do the maths. And we didn't randomise round numbers. Sorry.
Thank you.
Excellent. Thanks, Jonathan. Major achievement and much awaited. I'll go on to the next speaker. So invite Axel Bauer to talk to us about the Austrian digital heart study. Thank you, Axel.
So thank you very much for the introduction. Thank you for providing me the opportunity to present our program to this audience. I'll wait for the slides.
You point down here?
Yeah, it's fine, it's fine. So our program is called Austrian Digital Heart Program, and it's following a previous trial we conducted some years ago, the eBrave AF trial. And in this trial, we used common smartphones, participants' own smartphones, to screen by PPG-based methods for atrial fibrillation. And this was conducted completely digitally, remoteless, in a pragmatic trial. And we could demonstrate for the first time that digital smartphone-based screening can substantially increase the detection of treatment-relevant atrial fibrillation. These were elderly patients, 65 years, and you see that digital screening almost doubled the detection of treatment-relevant AF, which was defined as atrial fibrillation that was treated by anticoagulation by independent physicians across Germany. However, as everybody knows, the effect of such screening approaches on clinical outcomes is completely unknown. And this was the basis for us to launch the so-called Austrian Digital Heart Program, which is a publicly funded national initiative to develop and validate a digital framework for detection and management of atrial fibrillation, and to integrate this technology into a comprehensive system embedded into the Austria healthcare system. This program has several components: developing program, a small pilot study, and so forth. But the key component of this program is a large-scale randomized digital trial conducted at the population level. We will randomize more than 100,000 participants across Austria in a one-to-one fashion to either continuous PPG-based, smartphone-based screening and management, the digital arm, or standard of care. In the digital arm, people use their own smartphones, install a self-developed app on that phone, and start screening according to a specific schedule. And in case of abnormal PPG findings, an ECG patch will send to the patients for AF diagnosis. And importantly, of course, after diagnosis of atrial fibrillation, patients enter a dedicated telemedical supported treatment path, which aims to cover the whole spectrum of AF-related morbidity and mortality. The first patient will be enrolled in the next years. The trial will take its years, and we expect the results in 2031. This is a fully digital trial, which means remote recruitment, digital onboarding, and automatic outcome assessment. And it's also a technology-independent trial, which means we use brand-independent technologies. We implement a CE-certified tool into a self-developed app, the FibroCheck app, but people will use their own smartphones. And at the end of the study, the whole setup can be implemented into the Austrian healthcare system, so this will allow fully scalability. So this is a brief synopsis, and I want just to focus on one aspect, which I think is very important, the power calculation. And Paulos mentioned the loop study is a negative study. So the loop study actually randomized 6,000 patients. And in the end, they reported an effect size of 20%, 0.8. But this was, of course, not statistically significant. But is this then a negative trial? I don't think so. So I think it's a matter of power, most likely. And in our trial, we calculated that we need 100,000 participants to detect the superiority of digital screening with a power of 90%. We assumed an incidence of stroke, all-cause stroke of 1% per year, and we estimated or assumed a reduction of 10% by the intervention. So I think this is an important aspect which should not be neglected when thinking about the effectiveness of a trial, of a screening approach.
Thank you very much. And I think that's where exactly what Bill McIntyre said. If we have the possibility of doing an individual patient data meta-analysis in all these trials, even if it's 2030, we will know what are the things that are effective and how effective and what the effect size is. Much greater granularity than we could ever have done otherwise. Thank you very much, Axel. I'd now like to introduce Rob Tieleman, who is one of our original members right at the very beginning, from the Netherlands. You first did your screening with a handheld device during flu vaccination, and now you moved to check it at home. Thank you very much, Rob.
Yeah. Thank you very much, and thank you for giving the opportunity to discuss our trial here. Our trial indeed is called Check at Home, and it's a population study performed in the Netherlands. And we combine screening for atrial fibrillation with screening for myocardial. So this is not purely an atrial fibrillation screening, it's more a screening for people who have end-stage cardiovascular disease, because myocardial, of course, is a sign that there is damage to the kidneys, and atrial fibrillation is often the result of underlying cardiovascular disease. In a later phase of the study, we might adding screening for diabetes to it. It's a controlled randomized study, one-to-one randomization, in which we invite 320,000 patients in the age of 50 to 75 for screening. Half of them will be invited for screening and the other half will not. It's performed in 3 Dutch regions after each other, and we hope to learn from every region so that we can increase the response rate from screening. Next slide. Oh, I can do it myself, of course. In case of a positive home-based test, so in case the patient has microalbuminuria or an irregular rhythm as suggested by the Habitech app, they will be invited for screening in a screening facility, and there they get the regular cardiovascular workup. So an ECG is made, lab is taken, blood pressure is measured, and of course BMI is measured. And the results will be sent to the general practitioner and with an advice how to treat these patients. There are some sub-studies. Of course, we aim at atrial fibrillation with a very high burden. So either persistent atrial fibrillation or permanent atrial fibrillation, which is based on the studies with a low burden, which do not have a large effect. However, we will use e-patch for 5 days in a special cohort of patients to see whether that influences the results. How many patients do we miss? We also want to calculate, because this screening facility, inviting a patient there is quite expensive, so maybe it's more cost effective to first send them an e-patch like Axel does. We will use questionnaires to tailor echo screening in some patients, which will be a sub-study. In some, there will be a sub-study on calcium score in women, and a sub-study whether it's how much impact we increase by treating the patients also. So normally all these screening studies detect patients and send a letter to the patient and maybe send a letter to the general practitioner to start treatment or to visit your GP. But we know that we lose a lot of impact in that way because half of the patients don't do anything with it, with the letter, and then a subset of GPs also do not respond in the way that we would like to have them to respond. So we will have a randomization there just to see, in the first region, just to see how many more patients will be taking the medication that we advised, and that will depend whether we go on that way or not. So, in conclusion, 320,000 patients invited for screening. No, not invited for screening, randomized. Half of them will be invited for screening. Follow-up will be during 5 years, we'll be using Dutch hospital data database with claims data from the insurance companies and the Central Bureau of Statistics. The endpoint will be ischemic stroke or total, or I should say stroke, and total mortality, and the total budget of the study is about 9 million euros. Thank you.
Well, I think we congratulate you for getting on this. We congratulate you for getting on this, and Axel. So you can see, and Jonathan, that we are still very active in getting the numbers up. We will have lots more answers, or not more possibility of getting a positive answer. I'm very much aware that we are about 20 minutes over time. So I think we should relegate any questions on the individual studies. You have the assurance that AF Screen is entirely behind this process, and this is our main aim. This is the main part of our game. So we will continue to work with this and to make sure that we keep it going. Thank you very much. And so I'd like to ask Renata to just put some concluding remarks, and then we'll try and take a photograph of those who are left.
Exactly, the most important thing. So I can have up my slides. They are not very important, but my parting comments now. So 2015, 10 years ago, Ben started this whole effort of AF Screen, and the idea was to put together a collaborative group, and I think this collaborative thought and idea is still working very well to promote discussion and research about screening for unknown or undertreated atrial fibrillation in a way to reduce stroke and death and many other outcomes. And this still holds true. We are not there yet. We always ask ourselves, do we need to go on? But you see, with all these new studies coming up, new studies starting next year with all the new topics, we have a large group with very different experts, from general practitioners to neurologists, not only electrophysiologists and cardiologists. So a big dedicated group. This is last year's a meeting. We have had a group photo every year, so we need to have one afterwards. So please come to the group photo. And
will that be here, I think, on the
will
stage?
Be here or?
Yeah.
Okay. So then stay here in the room, and we'll be group for the group photo. And are there no longer enough topics? Of course, there are these new topics that have come up in 2016 when the first big meeting in Rome, 60 participants. Now we are still at more than 60, more than 70 participants. We did not talk about burden. We did not talk about atrial cardiomyopathy. And I think these are topics that are very relevant now, with more information, more in-depth evidence on atrial fibrillation screening. So new screening trials coming, and we will expect them during the ESC starting tomorrow and over the next years to come. So thank you very much to all our partners who made this meeting possible. Thank you to all of you dedicated researchers who give their input and their dedication to AF Screen, and I hope that we can reconvene in Munich next year for the next ESC in 2026. Yeah. Thank you.
I might. Are we going to have?
And then if you could all concentrate in the front rows.
Okay.